Distinguished guests, ladies and gentlemen, good morning and welcome all of you to join today's International Conference on Healthcare Reform organized by the Bohemia Foundation Research Center. The conference will be conducted in a multilingual manner. Simultaneous interpretation services will be provided throughout the conference. For the smooth proceeding of the conference, please turn off your mobile phone. May I now call upon the chairman and directors of the Bohemia Foundation Research Center, as well as the guest speakers and discussants to come up to the stage and be seated. Mr. Anthony Wu, chairman of the Bohemia Foundation Research Center. Secretary Gao Qiang, Ministry of Health of the People's Republic of China. Dr. the Honorable York Chow, SBS JP, Secretary for Food and Health of the Hong Kong SAR Government. Dr. Donald Lee, Director of the Bohemia Foundation Research Center and President of WONCA, Asia Pacific Region. Ms. Sandra Lee, Permanent Secretary for Food and Health of the Hong Kong SAR Government. Professor Nicholas Mays, Professor of Health Policy, London School of Hygiene and Tropical Medicine. Dr. Tanshan Lan of World Health Organization, China Office. Ms. Winnie Ng, Director of the Bohemia Foundation Research Center. Professor Chris Van Wil, President of WONCA World. Professor Sean Griffiths, Director, School of Public Health of the Chinese University of Hong Kong, and also Professor Gabriel Leung, Under Secretary for Food and Health of the Hong Kong SAR Government. Please be seated. May I now call upon our chairman, Mr. Anthony Wu, to give welcoming remarks. Chairman, please.
Honorable guests, distinguished speakers, ladies and gentlemen, welcome. Welcome to this International Conference on Healthcare Reform organized by the Bohemia Foundation Research Center. The Bohemia Foundation Research Center is an independent policy think tank set up in Hong Kong about 3 years ago. As a think tank, we attach a lot of importance to Hong Kong's long-term competitiveness and socio-economic well-being, and that's why we did a study into Hong Kong's healthcare reform last year, which had aroused a great deal of public interest into this very important subject. Today's conference is opportune as it is organized at the time when Hong Kong has just entered a new phase of healthcare reform. According to the first stage public consultation conducted by the Food and Health Bureau, there is broad support and recognition in the community on the imminent need for healthcare reform. We very much hope that this conference will provide a platform for top healthcare officials, experts, and stakeholders, both local and overseas, to exchange views and share the experience in healthcare reforms. I believe the diverse reforms experience of the mainland, the UK, New Zealand, and the perspectives of WHO and WONCA will offer us new perspectives and shed light on our way forward. Thanks must go to all speakers, panelists, and participants who spare time to join our discussion today, especially those traveling from overseas. Thank you once again, ladies and gentlemen, for taking part in this conference, and I look forward to a lively and stimulating exchange of views later today. Thank you.
Thank you, Chairman. Please move to the center of the stage to present souvenir to our guest speakers and discussants. First, we would like to invite Secretary Gao Qiang to receive a souvenir. 有请高书记。Thank you, Secretary Gao. Dr. the Honorable York Chow, please come forward to receive the souvenir. Thank you, Dr. Chow. Ms. Sandra Lee, please. Thank you, Ms. Lee. Professor Nicholas Mays, please. Thank you. Dr. Tan Shen Lan, please. Thank you. Professor Chris Van Wil, please. Thank you. Professor Sean Griffiths, please. Thank you. Professor Gabriel Leung, please. Thank you. Would Chairman remain on the stage and receive souvenir from Secretary Gao Qiang? Secretary Gao, please. Thank you. Please proceed to your seat on the floor. May all the guests and speakers proceed to your seat on the floor. We will start our program today in a few minutes. May I now call upon Dr. the Honorable York Chow to deliver an opening address entitled Healthcare Reform Consultation and Way Forward. Dr. Chow, please.
Mr. Wu, Secretary Gao, distinguished guests, ladies and gentlemen. First of all, let me thank the Bauhinia Foundation for this gathering of experts to brainstorm on the future of the healthcare system. Today's conference is a perfect occasion for us to take stock of where we are and see where we are going. We have just issued the report on the first stage public consultation on healthcare reform, and we are preparing for the second stage public consultation that we aim to initiate later this year. Healthcare reform is not new to our community. It has been discussed on and off for nearly 2 decades. The challenges faced by our healthcare system are clear and present. Our population is aging rapidly. Our medical cost is rising consistently. Meanwhile, the public system is being stretched to its limits, while the private sector is underutilized. And the over-reliance on heavily subsidized hospital care has contrasted sharply with the insufficient emphasis on primary, especially preventive care in the community. Over the years, we have been searching together with the community the answer to the question, how to ensure the sustainable development of our healthcare system. Previous discussions and overseas experience have shown us that the answer does not lie simply by injecting more resources into the healthcare system. We need to take a fundamental look of how we organize healthcare services and how the healthcare market operates. We need to examine how resources can be channeled to their best use in delivering healthcare that meets the needs of our population. Above all, we need to build a consensus in the community for change, as the future of our healthcare system rests with our community's choice and our society's values. We have therefore put forward, in March last year, a comprehensive package of reform in the document, Your Health, Your Life, and consulted the public extensively in order to identify a solution from a holistic perspective. The consultation outcomes are fruitful and encouraging. We received enthusiastic responses from a wide spectrum of the community, including many of those present here today, sharing their constructive views and, more importantly, showing their support and devotion to the future of our healthcare system. We attended over 150 consultations of various size and forms with different stakeholders and communities, received submission from over 4,900 organizations and individuals, and conduct many rounds of opinion surveys. So what the community has told us about what they want in the future of our healthcare system. Let me recap the key conclusions we have drawn from this extensive first round of public consultation. Firstly, the public strongly support reforming the healthcare system, and the majority agree that there is an imminent need to do so. Secondly, there's a broad consensus and support among the public for the proposals to reform healthcare services, and most look forward to also their implementation. Thirdly, 2/3 of the public agree with the need to change the way we finance healthcare, despite divergent views on how. Most agree that further in-depth discussions would be needed. Let me also add that the Hong Kong people care so much about the healthcare that they do not wish to see our effort to reform long-term healthcare delivery to be hampered by short-term economic woes. After the financial tsunami, that is in the last 2 months, we have conducted another 2 rounds of survey and found that over 70% of the public think we should still press ahead with the consultation and seize precious time to continue to build the consensus for reform. In short, the consultation reveals a strong public endorsement of our direction for reform, which aim towards the vision for a healthcare system that puts much stronger emphasis on primary and preventive care and better health outcomes for our people. Secondly, a healthcare market where the public and private sectors complement with a healthy dose of competition to meet the needs of our people. And thirdly, a healthcare financing arrangement that reflects our societal values to sustain the long-term delivery of quality healthcare to our people. So we have the answers on what. The remaining question is how. How to achieve a healthcare system that delivers all these. A system that emphasizes healthy outcomes with public and private coexistence and sustainable financing. The public has spoken with a clear message that they consider healthcare to be a high priority, and there is a strong public support that more resources should be devoted to healthcare, and government funding should continue to be the major financing source for our healthcare system. Indeed, the government's commitment to healthcare will only increase and not be reduced. We will be making good our commitment to increase our recurrent government expenditure on healthcare from 15 to 17% by the year 2011-2012. Yet, given Hong Kong's small government principle and low tax regime, most agree that government funding alone is not going to be sufficient to meet our future healthcare needs, let alone sustaining the reform initiatives. To ensure the sustainable development of our healthcare system, the question of how could not be solved simply through continuing to increase public spending while passing the medical bill to taxpayers and future generations. So the most challenging task is how best to gather and channel resources in the society to meet the increasing healthcare needs of the community. It is on this question that there are still divergent views and further deliberation is needed in the community. But we are certainly not starting from scratch. Let's begin with where the convergences are. First and foremost, the public treasures existing accessible and equitable public healthcare systems. They value our public healthcare system and believe that it should continue to provide protection for the underprivileged and the unfortunates. Everyone agrees that a tax-funded public healthcare safety net accessible by all must be retained, and indeed should be strengthened to ensure that adequate healthcare protection is afforded to those in need. Any other financing arrangements must be supplementary. At the same time, most people prefer having their own choices of healthcare over and above the basic healthcare safety net and prefer supplementary financing arrangements that will provide them such choices. Many are already seeking healthcare from private sector through their own means or can afford so. They're looking to the government to provide them with better and wider choices in the market, especially more transparent and informed choices. They're also looking to the government for incentives to do so. Thirdly, among those who can better afford to use private healthcare, there's a strong tendency to favor risk pooling over merely saving for their own healthcare. Many people recognize the shortcomings of existing voluntary insurance, which tend to debar the sick and the elderly. Many also acknowledge that the most effective way of risk pooling is by way of mandatory insurance. This notwithstanding, there is a general preference among the public to retain the voluntary choice in any supplementary financing arrangements. What do these suggest for our way forward? I will characterize the way forward in three-pronged strategy. Firstly, service reform. With the clear public support and consensus, we'll be pressing ahead with the service reform proposals. We're working with the healthcare professions to take forward our primary care reform proposals with the aim of bringing to the public more comprehensive and holistic primary care services that focus more on bettering health and not just curing illnesses. In doing so, consensus building, public-private partnership, and vouchers will be essential tools for facilitating and incentivizing desired changes in behavior of both patients and healthcare providers. We'll also be building the electronic health record system in collaboration with the private sector as a necessary infrastructure to support these reforms. Secondly, the public system. We will strengthen the role of the public healthcare system as a safety net and reaffirm the four target areas of public health services, looking after the acute and emergency, the low income and underprivileged, doing the high-cost, advanced technology and multidisciplinary long-term care, and training and development of professional staff. We will ensure that assistance is available to those in need, especially patients requiring expensive treatments. Outcome-oriented resources allocation within the public healthcare system and public-private partnership implementing the money follows the patient concept will be essential means for delivering more efficient and cost-effective healthcare services. Thirdly, the private market. Meanwhile, we will find means to enable better and wider choice in the private market for those who are using or can afford to use private healthcare. To do so, we need measures to promote the development of the private healthcare sector, including making sites available and providing the right policies. We need to make public-private partnership a key component of our healthcare delivery to encourage collaboration amidst healthy competition. We also need to proceed with financing reform through a step-by-step approach, considering supplementary financing arrangements that provide standardized and incentivized means for assessing choice in the private market while catering to the needs of different age and income groups. Let me elaborate further on this final prong of our strategy. While we still envisage the long-term solution to sustainable financing rests with some form of mandatory solution, and indeed the International Monetary Fund has drawn similar conclusion in its recent review of Hong Kong's situation, we do not believe that the community is ready for mandatory financing at this very point of time. What we would like to examine is therefore how we may take forward proposals in stages that can bring us closer to achieving a long-term solution. In doing so, our focus is whether we can have a better arrangement for the public as a whole than at present. In my mind, a better arrangement must include the following. First, the private market must be able to offer better choices to consumers in terms of both quality and price transparency. For private health insurance, for instance, it must be able to address the existing shortcomings, providing the insured with certain basic standardized, consistent, and transparent terms and sustainable coverage at the very least, offering adequate protection as well as continuity and portability, allowing the elderly and those with illnesses to enjoy affordable access as well. Moral hazards and possible abuses should be minimized. For private healthcare services, quality assurance and price transparency will be essential. Second, the arrangement must enable a larger proportion of our population to access private healthcare services as an alternative choice to public healthcare. It must also be able to increase significantly the pool of people who could afford to access private healthcare. This is essential to relieve the demand on the public healthcare system and benefiting those who need to rely on public healthcare for lack of means. This condition is particularly important if incentives are to be provided through the arrangement using taxpayers' money for those who could afford to access private healthcare. Third, there must be a clear roadmap for the transformation of the arrangement into a long-term sustainable solution. This would necessarily require a component that would save up to meet future healthcare needs. It would also mean the arrangement must be able to bring about certain key features that would pertain to a mandatory solution, such as effective risk pooling. This is by no means an easy task, but we must firmly set our eyes on the long-term sustainability of our healthcare system. If I may digress a little, just to talk about an idea that has been mooted to provide financial incentives, such as tax exemption for premium of existing private medical insurance, or for medical expenses on private healthcare services. The idea is simple, and it can easily capture people's mind, and often on politicians' lips. Some suggest it as a possible interim solution to healthcare financing, but we need to assess this idea carefully against the above criteria. If tax exemption is provided for existing private medical insurance without any regulation or prerequisites, it would only perpetuate or even aggravate the existing shortcomings of such insurance. The insurer still would not get any better terms or continuity, and the high-risk groups and the elderly still could not get insured. There would also be little control over future premium hike as a result of increasing healthcare utilization and costs due to moral hazards. While it may serve the purpose of enticing more people to take out private medical insurance, thereby resorting to private healthcare, there is no guarantee that these would go in the direction of relieving demands on the public healthcare system, and more importantly, by improving healthcare outcome. The situation is even grimmer with tax exemption for private medical expenses. Experience has suggested that effective healthcare financing requires some form of prepayment. Unqualified incentives for direct private medical expenses would only increase consumption for unwarranted healthcare services and benefit only those who are already using private healthcare services using their own money. Given the information asymmetry and lack of price transparency, the incentives are also likely to result in price inflation of medical services rather than benefiting patients. We have seen this in some countries already. We must take care to avoid a situation that would be worst of all worlds. Back to the reform. As the saying goes, Rome is not built in one day. We cannot expect reform to be successful overnight. But we now have a solid foundation upon which to launch a more focused and in-depth discussion in the next stage. Building on the outcomes of the first stage public consultation, our challenge now is to work on the basis of what the public has told us and develop a package that would help to galvanize a consensus in the community to take forward the financing reform. No doubt, we will need to create room and opportunity for more thoughtful discussion, to review our proposals, and to fine-tune our plans during the process. But time is of essence, and we could not afford any more delay in reforming our healthcare system. Any further delay would only put the sustainability of our healthcare system in jeopardy. Last but not least, collective wisdom and sense of ownership of the community will be indispensable for the success of the reform. Where healthcare is concerned, everyone matters. We must therefore engage the public and stakeholders in finding our solution. The private sector, be it the healthcare professions or the insurance sector, will play a crucial role in meeting the public expectations for healthcare reform. And I'd like to call upon them to work together with us in delivering them. Today's conference is an opportunity for minds to meet and for new ideas to brew. I'm sure we all have a future sustainability of our healthcare system at our hearts, and look forward to the heart-opening exchanges today. I'm very glad that the government has introduced the new accountability system to allow undersecretaries to work with us. So it is nice for me to speak my mind and let the undersecretary answer all the difficult questions later on. But in order to ensure that discussion will go along some of our basic principles, I would like to summarize 4 cardinal principles that are important for our healthcare system. First, the government has commitment to ensure the system works. In other words, we have commitment to deliver and also to build an environment of healthy delivery of services. We will never shed away the responsibility of overseeing, supervising, as well as financing our public healthcare system. The public healthcare system is essential for a healthy community. This is the first point. And second point, we must not go away without thinking what the public and patients want. We must educate the public, educate them so that they understand and have the right expectation of health outcomes, and also understanding the limitation of healthcare services. They also need to have self-responsibility so that they can adopt the right behavior, both in lifestyle as well in seeking health services. And lastly, they have also need to understand the value and cost of services so that they can contribute appropriately to the financing of the system. Thirdly, I talk about the healthcare providers and professions. They need to adopt a patient-centered approach, the right attitude, and understand the holistic care principles of healthcare today. They need to accept there is a multidisciplinary teamwork required for healthcare. It is not something that can be delivered usually by just one profession alone. And they need to compete for better health outcomes, professionalism, and ethical practice. They also need to proactively establish a good patient and doctor, patient and carer relationship. This is an important part to ensure that we have a trusting relationship between the carer as well as the public. And for financing, that's the fourth point, we must ensure there is a good safety net that can take care of the disadvantaged and the needy. We have outlined the 4 priorities of the public healthcare system, which I will not actually repeat. Also, we must ensure that the pricing of services could be made affordable, but also with a component of co-payment so that this would diminish abuse and inappropriate use of our services. And last, we must find a sustainable healthcare financing solution for the community. We have to look at each country and each place's fundamentals, and Hong Kong always like to adopt a low tax principle in our financing. So we must look at alternative way of achieving the supplementary financing. So I hoped that in this discussion that follows, I hope that Gabriel will have to address that, that we were able to look at how the existing shortcomings and what are the important gaps we need to fill in the coming months. I'm talking about months, and actually not years, because I hope that we can make certain decisions within a short time. We might not be able to address everything in one go, but anything that we can do to get a step closer to our goal would be an achievement. So with that, I'd like to thank every one of you. I'd like to also take this opportunity to thank Secretary Gao for able to come to Hong Kong and share with us his vision on a much bigger reform, a reform I think would benefit the whole of China, including Hong Kong. So with that, thank you very much.
Thank you, Dr. Chow. May I now call upon Secretary Gao Qiang to speak on directions and principles of healthcare system reform in the mainland. 有请高书记。
尊敬的主席先生、各位来宾、女士们、先生们、朋友们，感谢香港的同仁和朋友邀请我参加这次医疗改革及未来路向的研讨会。我首先代表国家卫生部向这次研讨会的召开表示热烈的祝贺。医疗体制是一项关系民生、关系社会稳定、关系医患和谐、关系经济社会持续协调发展的一项重大的社会制度。医疗体制的基本含义是确定政府、社会和居民个人三方的利益关系，正确处理好这三方在医疗服务中的权利和义务。医疗体制的建立与一个国家和地区的国情、区情以及经济社会发展的水平有着密切的关系，与广大居民的健康需求有着密切的关系。也可以说，有什么样的国情、区情，就有什么样的医疗体制；有什么样的经济社会发展水平，就应该有什么样的医疗体制。这个体制和国情、区情和经济社会发展水平要相适应，既不能超前，也不能滞后。如果医疗体制超过了一个国家和地区的经济承担能力，超过了居民的个人负担的能力，那么这个体制就不可能持续协调的发展。如果医疗体制滞后于一个国家和地区的经济发展水平，不能满足居民的基本医疗健康的需求，那么这个体制也不会得到社会民众的拥护和支持。香港的经济社会发展水平高于内地，区情和内地也有很大的差别。按照一国两制的原则和香港的具体情况，探讨香港的医疗体制改革，研究建立符合香港区情的医疗体制，对于改善香港人民的健康和福祉，维护香港的长期繁荣稳定和发展，以及保持香港医疗体制的可持续性的发展，都具有重要的意义。中央政府一直高度重视人民的健康，把健康作为人全面发展的基础和民生治本，强调要把维护人民的健康放在卫生工作的第一位，将实现病有所医 和人人享有基本医疗卫生服务作为全面建设小康社会的重要目标之一。根据当前内地医疗体制存在的问题和广大人民群众的意愿，中央政府决定在今年将全面启动新一轮的医疗体制改革。利用这个机会，我想向诸位简要地介绍一下内地医疗体制改革的方向、目标、基本原则和主要的工作。第一，内地医疗体制改革的背景。中国内地的医疗体制改革与1978年的中国的改革开放同步进行。当时，医疗体制改革的基本导向是针对国家经济发展水平很低、医疗资源严重短缺、人民群众普遍缺医少药的情况，对医疗卫生机构实行简政、放权、让利、搞活，鼓励多渠道、多种形式兴办医疗事业，调动医疗机构和医务人员的积极性，最终达到扩大医疗服务供给的目的。实践证明，30年来的医疗体制改革打破了政府包揽医疗服务的格局，调动了医疗机构和社会办医的积极性，使内地的医疗服务体系发生了重大的变化。医疗卫生机构的总数由1978年的16万7千家，增加到2007年的29万8千家。病床的床位由204万张增加到370万张，卫生人员由310万人增加到590万人，诊疗人数，医疗机构的诊疗人数每年由10.1亿人增加到28.4亿人，人民的健康水平也显著的提高。按照世界卫生组织确定的衡量国民健康状况的3大指标，内地的人均期望寿命由1978年的68.2岁增加到现在的73岁，孕产妇的死亡率由1990年的10万分至88.9，下降到2008年的10万分至34.2，下降了61%。婴幼儿死亡率由1981年的1000分之34.7，下降到2008年的1000分之14.9，下降了57%。这些健康指标和香港比起来还有很大的差距，但是在发展中国家已经居于前列。有一些地区，有一些省份，特别是一些沿海的东部地区省份，已经达到了中等发达国家的平均水平。 但是在医疗体制改革取得巨大成绩的同时，也出现了一些突出的问题，主要是在强调动员社会力量发展医疗事业的同时，忽视了政府的主导作用。财政对卫生的投入比例逐年下降，直接的后果就是政府配置资源的职能弱化，医疗服务的公益性淡化，人民群众的医疗负担加重。1980年，政府卫生支出占卫生总费用的36.2%，这是中国内地的政府投入比例的最高水平，1/3强一点，香港是92%，内地无论如何达不到。13亿人医疗卫生负担由政府负担这么高是达不到的。但是从1980年以后，政府投入的比例逐渐下降，2001年下降到15.9%，下降了一半还多。而居民个人的负担由21.2%提高到60%，所以内地群众一直反映看病贵、负担重。通过这个数字可以说明，近几年来政府的投入大幅度增加，这个比例也在发生一些积极的变化。到2007年，政府的投入已经提高到20%左右，居民的负担已经下降到45%左右，就是由2001年的60%下降到07年，6年之中下降了15个百分点，这也是一个很积极的变化。当前的内地的医疗体制还有一个问题，就是医疗资源配置的结构不合理，优质的医疗资源过多的流向经济发达地区、经济效益好的大型医院，而公共卫生还比较薄弱，一些经济收益较低的农村卫生机构、社区卫生机构，长期改变不了条件差、水平低、资源少的状况。大家印象最深的就是2003年爆发了波及全国的 SARS 疫情。这个问题引起了中央政府和内地全社会的广泛的关注。大家都在思考，为什么在中国经济社会快速发展的情况下，会爆发波及全国的 SARS 的疫情？其实现在看来，SARS 疫情要从医学的角度来讲，并不是很严重。全国不包括香港，不包括台湾，死亡的是349人。其实每年的一个普通感冒，那死亡的人数就大大高于这个数字。患这个 SARS 疫情的人、病情的人只有5329个人，这个数字也不是很大。但是为什么引起了 全社会的恐慌，反映出我们的公共卫生体系存在着很多问题，很多薄弱的环节，不能够有效地去应对这种突发的公共卫生事件。所以从2003年以后，中央政府决定大范围的、高强度的加强公共卫生体系建设，包括疾病预防控制，包括食品药品安全监管，也包括一些妇幼保健等等精神卫生这方面的一些建设，取得了明显的成效。大家也可以看得出来，从2003年到现在5年以后，没有发生大的传染病的疫情，一些零星的所谓禽流感等等这些，虽然每年都有零星的发生，但是影响很小，并没有影响到社会的安全和稳定。从03年到08年，内地只有31个人患禽流感这个病情，然后每年5个人、5、6个人，这已经不是一个非常突出的问题。对于这些问题应该怎么看，我们也在反思。我们认为，任何一个改革都是一个长期的过程，不可能一蹴而就，也不可能一劳永逸。我赞成刚才周局长讲的话，罗马不是一天建起来的，香港和北京那更不是一天建起来的。任何一个制度的建设和完善是一个长久的过程，要说的更极端，是一个永远的过程，不可能完善，也不可能到此为止。所以我们对任何一个改革，要肯定它过去的成绩，不能全盘否定。前2年，内地有一些舆论讲，中国的卫生改革是不成功的，这话是不对的。它不成功，刚才我讲那些数字，它就不会出现。中国的卫生体系不会有这么大的变化，这是一个方面。另一个方面说，内地的改革就是非常成功的、完美无缺的，也是不对的。不光中国没有这个情况，任何一个国家都没有这种情况，它是不断在发展变化的。事物的发展规律总是旧的矛盾解决了，新的矛盾又出现了，然后我们再集中精力研究解决新的矛盾，那是我们的管理水平和发展的能力提上一个新的台阶。但是后来还会出现新的矛盾，事物永远是这样的。所以人类社会的发展就是一个辞旧迎新的过程。邓小平同志过去1993年就说过一句话，他说过去我们总是讲先发展起来再说，现在看呢，发展起来以后的问题并不比不发展的时候少，现在可能比那时候更多。这各方面的矛盾呢，人们的需求啊，当然还有一些民主的这个进程啊，都有表达自己意愿的权利。整个的社会会出现的矛盾，比30年前要复杂得多。但是我们现在存在的问题，是发展中的问题，是新阶段更高层次上的问题。如果没有这30年的改革发展，现在存在的问题可能没有，但是也更没有现在中国的发展和变化，那中国就永远会处于一个落后的状态，在世界上永远没有现在所拥有的地位。 这个很难想象，如果没有改革开放这30年，中国到底还是个什么样子，想象不出来。所以我们要正视存在的矛盾和问题，也要坚定信心，既不要骄傲自满，也不要老否定自己的一切，要敢于解放思想，迎接挑战，继续的推进改革，在改革中实现前进的目标，我们就会登上一个新的发展阶段。内地的医疗体制究竟存在的核心问题是什么？在内地也有两种不同的意见。一种意见说是政府的作用没有到位，它有它的道理。刚才我说了一些数字，也说明了政府的投入是不足的。全国各级政府用于医院的投入，平均起来只占医院收入的7%。这个胡主席说，香港是92%，92加上我这7呢，两地加在一块儿是100%，差不多。这是不足的。但另一方面讲呢，市场机制有另一个观点呢，就是市场机制远远也没有充分的发挥作用。这观点也不错，为什么呢？现在的内地的医疗卫生资源95%以上还是公有的，那私营的，如果按照这个医疗机构的个数来讲，很多，它占到70%了，但是很小，它规模很小，占的资源很少。从这个意义上讲，我们又没有利用好这个市场的机制。但是进一步再说，虽然公立的医疗机构占了这么大的比重，但是公立医疗机构的运行机制又是高度市场化的。政府投入很少吗？它就是靠向群众提供医疗服务、收费来维持它的运行和发展。包括医院现在有买一些大型设备，盖一些这个门诊楼等等，包括这医生的人员工资都是要靠向群众看病收费来解决。那这个市场机制有高度发达，所以内地的这个医疗体制是一个矛盾的，各方面的问题都存在，所以解决起来可能比香港还要困难。再加上我们的人太多，各种需求不同，国家的经济财力嘛，和香港比起来呢，又远远不如，所以这个困难会比香港解决起来要大得多。但是我们对此有信心，因为我们已经具备了一些比较好的推进改革的条件。第一，我们现在内地已经进入了全面建设小康社会的一个关键的阶段，而且中央政府是把这个保护人民的健康作为建设小康社会的一个重要的目标。人民群众的收入在不断的增加，生活水平也在日益的改善，所以大家对健康的需求比过去有了很大的提高。我们有一句话呀，过去说人的这个生活4门功课，衣食住行，现在有点变化。 现在叫衣食住行。这个衣是医疗的医，不是衣服的衣。好像我看不出来哪一个人为穿衣服发愁，无非好一点坏一点嘛。但是医疗，人人都不可缺少的，不管是有钱人还是低收入阶层，他都希望享受到最好的服务，尽快的恢复健康。人的生命总是第一位的。第二，我们现在是贯彻这个以人为本的理念，要把人们的健康和生命放在一切工作的首位，要注重社会的公平，要更加注意改善民生。第三呢，我们这个经济啊也是快速的发展。财政收入1978年只有1130多亿人民币，2008年已经超过了6万亿，30年由1000亿增长到6万亿，60倍。今年呢，虽然面临着一些经济上的问题，既有国际金融危机的影响，也有我们自身的这个经济发展中存在的一些问题，所以带来了一些困难。但是我们有信心、有决心，也有根据，能够实现8%的增长。这是给大家讲的介绍的第一个情况，占的时间是不是太多了？第二是给大家介绍内地医疗体制改革的方向、目标和原则。卫生事业是政府实行一定福利政策的社会公益性事业，要坚持为人民健康服务、为国家经济社会发展服务的方向。其实我们建医院、培训医生，目的是什么？目的不在于你这个医院本身的发展，而在于你为群众提供什么样的服务。医院的发展的目的也是为群众提供服务。如果你发展的后果，群众享受不到你这个服务，或者是收费太高，享受不起你这个服务，这种发展是没有意义的。所以发展也需要和国家的经济水平和群众的承受能力要紧密的结合在一起。内地的医疗体制改革，其实概括起来，它的基本目标有3个。第一，是将基本医疗卫生服务和医疗保障覆盖城乡全体居民，落实医疗卫生服务的公益性质，为群众提供安全有效、方便价廉的基本医疗卫生服务，以体现社会公平。医疗卫生这个概念是个很难说清楚的概念。任何一个国家要把居民的医疗卫生需求全部包揽起来是不可能的。咱们要开句玩笑话，医疗卫生的需求，其中可能还包括这个长生不老，但是没有任何人能做得到。政府首先要明确自己的责任，我为群众提供什么样的服务，并不能说所有的服务都由政府提供，做不到。但是反过来说，也绝不能把所有的医疗服务都推给群众，你自己去承担去，更不行。所以一开始我就讲，这个医疗体制一定要把这个政府、社会和居民3者的定位，它的责任、义务 要讲清楚。而政府的责任就紧密地和国家的经济发展和财政预算收入水平密切相关。我们现在基本定位在，可以说3个概念。第一个，公共卫生服务基本上由政府承担，由政府筹资无偿的为居民承担，这就是体现预防为主。第二，基本医疗服务由政府、社会、居民3方共同承担，就是通过建立不同形式的医疗保障体系，使大家都能参加到这个医保体系中来。对有些困难居民出现问题，政府给予补助，帮助他参加医保。这方面就是三方共同承担。而一些特殊的服务，超过国家支付能力的服务，要通过商业保险，由个人支付，基本是要明确这3方面的这个责任。第二个目标呢，是要调动广大医务人员的积极性，这一点也是非常重要的。我们在改革中要强调，既要体现公益性，也要调动积极性。只有公益，只有公平，没有积极性，它就没有效率。这个医生的服务效率高低啊，和他的积极性有着密切的关系。因为别人都不知道你那个病是该怎么治的，病人也不知道，只有医生知道。医生如果是高度负责的，全心全意为人民健康服务的，他会提供很好的服务，体现人文关怀的服务，提供一些效果非常良好的服务。如果说他没有积极性，他的责任不到位的话，那种服务质量就会打很大的折扣。所以在改革中，医务人员的积极性一定要注意保护。第三，就是根据不同的医疗水平、不同地区的这个卫生发展、这个经济发展水平，合理的确定各方面支付的范围和能力。医疗体制的改革是一个复杂的社会工程，涉及到各方面的利益的调整，要同筹兼顾，要协调推进，不能顾此失彼。既要坚持医疗服务的公益性，也要调动医务人员的积极性；既要注意公平，也要注意效率；既要注意发挥政府的主导作用，也要注意调动社会办医的积极性。过去其实我们多年来一直也是主张利用社会资金发展医疗服务，但是政策上存在着很多的障碍，我们要调整，要制定一些鼓励社会办医的一些政策，把社会上的拥有的一些资金、人才吸引到医疗卫生服务上来。在这方面，我们也欢迎香港的医务界，香港的各方面能够到内地去投资、办院、发展医疗卫生事业。概括起来，内地的这次医疗改革的原则一共有5条，我就给大家介绍5句话。第一，是把维护人民的健康权益放在第一位，遵循公益性的原则，着力解决群众反映突出的问题，保证全体人民病有所依。 第二，坚持立足国情，走自己的路，不盲目照搬发达国家的模式，探索中国特色的医疗卫生道路。第三，坚持公平效率的统一，实行政府主导与发挥市场机制相结合。第四，坚持基本医疗服务水平与经济和社会发展水平相协调，与人民群众的承受能力相适应，不能过多的依赖新技术和新设备，要坚持中西医并重，要重点加强基层、农村和社区的卫生发展。第五，坚持统筹兼顾，既要解决当前的突出问题，又要注重长远的制度建设，正确处理好政府、医疗机构、医疗企业、医务人员和人民群众之间的利益关系。第三大问题，我简单的给大家介绍一下当前我们主要做的工作。第一，加快推进基本医疗保障制度建设。从今年开始，我们要将这个城镇职工的医疗保险、城镇居民的医疗保险和农村合作医疗制度全面推行，争取3年内，在13亿人中，参加医疗保险的人群要占到90%以上。而且随着经济的发展，不断的提高政府对于困难人群参加医疗保险的补助水平。第二，要建立起科学的基本药物制度，对于基本药物的目录的遴选、药物的生产、采购、配送、使用、价格等，都要规定起，制定一套比较严格的管理制度，使人民群众能够公平享有到安全有效价廉的基本药物。其实大家反映内地的看病贵啊，主要是药物贵，药价太高，出厂的价并不高，经过流通环节多次转手倒卖，到了医院就很高了，医院子还有加成，那就卖到患者的高了，不合理啊。第三是健全农村和社区的医疗卫生服务发展，特别是结合这次中央政府要扩大投资、拉动内需，实行积极的财政政策，要加大农村和社区的医疗卫生机构的建设，改善它的环境和条件。第四，促进基本医疗卫生服务的均等化。公共卫生服务主要是靠政府投资，靠政府组织卫生人员向群众免费提供。我们这个要扩大它的范围，要加强它的力度，要提高它的服务质量，特别是针对当前一些严重的危害人民健康的传染病、慢性病，包括这个恶性肿瘤啊、心血管病啊、糖尿病等等，这些要通过日常的预防医疗服务，帮助大家改变一些不良的生活习惯，提高他的健康素质。这个方面是我们今后几年的重点加强的工作。第五是对一些大型的公立医院改革要开展试点。总的来说，大型医院的改革比这个农村和社区的卫生机构的改革要复杂得多。它涉及到各方面利益的调整，而且现在的很多主要的矛盾都集中在大型医院上。我们要改革要推行试点啊。这个经过3年的努力，探索着一个比较科学合理的公立医院的管理体制和机制。改革的目标 既要使大家能够少得病、不得大病，提高健康素质，同时也要能够保证人民群众能够看得上病、看得起病、看得好病。这几条啊，说起来很容易，但涉及到各方面的要求。这是我给大家介绍的内地的新一轮医疗改革的一些基本的框架和原则。健康是人类追求的永恒主题，提高国民的素质是经济社会发展的根本目标，也是政府、社会和居民的共同责任。人类对健康的需求永远不会终结，医疗体制改革也不会终结，需要我们根据新情况、新矛盾和人们的新需求，不断探索新的解决办法。香港的经济社会发展水平很高，面临的改革任务与内地也不相同，但是坚持为人民健康服务的方向，我们是一致的。我希望在医疗体制改革的方面，香港和内地要不断地加强合作和交流，相互借鉴经验，凝聚智慧和力量，共同推动民众的健康与福祉。再过1周，海内外中华民族共同的节日新春佳节就要到来。在此，我代表国家卫生部向在座的各位朋友，并向香港医疗卫生界的全体同道致以新春的祝福，祝大家新春快乐，身体健康，工作顺利，阖家幸福。谢谢大家。
谢谢高书记。
占时间太长了，对不起大家。
May I now call upon Professor Chris Van Wil to give us a presentation on the topic entitled Role of Primary Care and Family Physicians to Secure Relevant Healthcare for Populations and People. Professor Van Wil, please.
Mr. Wu, Chairman of Bauhinia Foundation, Secretary Chow, Secretary Gao, distinguished guests, thank you for inviting me to this most important conference here. I'm delighted to be in Hong Kong again, although this time for a very short time only. As a title of my presentation, I borrowed from the WHO World Health Report that, with some form of impatience, presents the case of primary care, now more than ever, and I think that is truly summing up the situation in which we are. The need for healthcare that is robust, steadfast in addressing populations and people's health is more than ever important. Important to be able to do and achieve two moral duties. First, to provide care that is equally good in every population, in every country around the world, equality. And at the same time, that is responsive to people's and populations' highest needs, equity. And in innovating healthcare, as so often, we discover that there is a need more to better make use of what we already know than that we have to rethink and rediscover everything de novo. And for that reason, part of my presentation is bringing you back to the history of family medicine and general practice, going back for the future for healthcare in the 21st century. What I would like to do with you is to base my presentation on the model of the ecology of medical care, share with you two research examples, and work for conclusions on integrated primary care. But first, the background against which we discuss the innovations of healthcare. It's because everywhere in the world we've had too much reliance on a specialty model, a model of a doctor for every single disease, a model in which there's an over-reliance on technology and supplier-driven rather than response to needs, where diseases are seen in isolation, isolated from the society in which they occur, and with undue emphasis on just the disease mechanisms and the biomedical side of it. And even worse, doctors treat disease, episodes of disease in isolation, which leads to disruptive care. And one of the most disruptive factors is that we have segregated mental health from physical health, the body-mind anomaly. So that is the background against which most of this works. Now, if we discuss primary care in an international framework, one of the big problems is that healthcare systems differ, countries differ, and as a consequence, at first sight, healthcare and primary care in each country is quite different. It's important to find a common denominator to talk about, and the model of the ecology of medical care gives exactly that model. Ecology of medical care, and I present here US data. I should have presented data from Hong Kong, but it was only shortly before my presentation that Professor Leng indicated to me that these data are available. He has published it. So I learned already a lot from my visit to Hong Kong today. And it's in fact, it is just making the point I tried to make. In every country, we find this model in the same, more or less in the same way. And what is it? It's interesting, it forces us to have a, to have a population perspective and look at populations. And in every population, we will find that there is a large amount of episodes of poor health. When we take questionnaires from people, round about 80% of every sample will tell us that they have experienced in the last, say, couple of weeks, at least a day, an episode of which they didn't feel well. And of course, this is the recruiting ground for professional care. Most people feeling ill will consider visiting a doctor. But in the end, no more than 1 in 10, roughly 1 in 10, will go, and 9 of the 10 will take care of themselves. And the ones who go and visit a doctor visit primary care, irrespective of the system. And primary care takes care of the large majority of presented health problems. Usually we find something like 90% treated in primary care, 10% or less ends up in the hospital setting. In the Netherlands, after 20 years of very substantial investment in primary care, we now see that family doctors and the primary care team takes care of more than 95% of all health problems. A huge sector seen in primary care alone. Now that is the common ground internationally of primary care. And variations we see between countries are mainly due to how we steer this, how we navigate this, and how we organize this. Not reflecting differences in skills and knowledge of medical professions. And the ecology model, in a very clear way, gives the way how we can organize care from the community basis. And there are three important sectors. There's the domain of self-care, when most people take care of their own illness most of the time. Wouldn't it be a good idea to strengthen that? There's the domain of primary care that takes care of most health problems presented to medical professions. Shouldn't we strengthen that sector? And the secondary care, which is the result of highly selected cases, shouldn't we build that on taking care of that highly selected sector of health problems? That is what the healthcare structure should be able to do. But in reality, we are going the other way. We try to change the over-reliance on the hospital. We try to move people from hospital to primary care, from the specialist to the community, from the professional to self-care, and take into account much better than we've done so far the societal needs of medical care, healthcare, and prevention of health problems. And this gives us what the reach, what the domain of primary care actually is. It is a substantial part of illness and disease entirely seen in primary care, a unique domain for which we should train doctors, train nurses, train other professionals to cope with. I can share with you that domain from data from the Netherlands. This is a slide I've added to my presentation after the print was made that's been handed out to you. This gives, for example, the top 10 chronic diseases for family doctors in the Netherlands. Well, it summarizes the health problems of the Dutch population. Where are the problems that influence the health status, that determine the survival of the Dutch population? Where are they taken care of in primary care? And what you can see, and I think that is what makes it relevant for doctors and for Hong Kong as well. It's a mixed. This is cardiovascular diseases, respiratory diseases, mental health, it's skin diseases, it's everything together, unselected, treated in primary care. But primary care is more than just a unique domain. It also has three other important aspects to deal with. First, I think very important to realize, every primary care is always based in a community. And as a consequence, it reflects the health status and the health needs of that community. And that's the reason why practices within a small geographic area may vastly differ. Differ because the population they serve differs. And that gives us a huge mechanism to respond to differences in needs and to allocate intersectorial. Substantial part of healthcare is related with interventions that have nothing to do with medicine, but with other societal actions. The second part of primary care, it's the patient perspective. This is where we have a personal doctor. This is where we have the possibility of empowering patients in taking better care of their own health. And a third part of primary care, by navigating the system, it can influence the performance, the costs made, the outcome of of health care. Now that is the reach of primary care, and that is why, in fact, why we are here. And we're probably here because of this publication, 1994, publication of Barbara Starfield, who I think for the first time published the consequences of having a primary care structured healthcare. She compared a couple of countries, and she allocated these countries according to the amount of how the country was organized on the healthcare was organized on the basis of primary care. Countries here together, the United Kingdom, Denmark, the Netherlands, were the countries with the highest amount of primary care. The US, Germany, Belgium, at the time of this study, had virtually no primary care at all. And what this graph impresses so clearly is that the more primary care, the more health outcome for every dollar, euro, pound spent in the healthcare system, or with more money spent, better outcome achieved. This was the first time that the consequences of primary care were presented so loud and clearly. And quite interestingly, and I made a little modification of her graph, is in the middle were countries, Spain, Finland, Canada, Sweden, at that time, that had organized primary care, but differed from the UK, the Netherlands, and Denmark in that patients had to go through primary care, but could choose any practice they wished to access healthcare, contrary to the traditions in the other three countries, in the Netherlands, in the UK, in Denmark. Patients are listed with a personal family doctor. And as a consequence, the bond between the patient and the provider is, through the organization of care, very, very strong. And that provided the best outcome. And that is a reason why it might be interesting to share with you a little bit about the performance of family physicians and to go back a little bit in time, and that's why I have this Norman Rockwell painting of 1947. I'd like to share two studies that focus on the family physician. The first one is looking at the implications of the epidemiological setting in which doctors work. The other one is related to patient-centeredness. My first example is an old study, 1982, a study done by two educationalists in the Netherlands who were interested in comparing the performance of family doctors, family physicians, and physicians of internal medicine. And they used the case of hypertension to base their study upon. They exposed a group of family physicians and physicians in internal medicine to a case of uncomplicated hypertension and a case of complicated hypertension. And this is, we have to realize, in the time before we had any empirical data of the performance of family physicians. So this was one of the first studies, and I still can remember how surprised the researchers were when they looked at the performance of family doctors caring for hypertension. They were impressed by how efficient family doctors were. They used a few interventions. They, in a limited amount of time, very purposeful way, they moved to exactly the important issues to decide. Well, that was quite in contrast to what happened when family doctors were confronted with a case of complicated hypertension. Immediately, their performance changed. They use more interventions, more time, and they applied a much more explorative approach. And that again was in contrast to the physicians of internal medicine. Physicians of internal medicine with complicated hypertension were, so to speak, protocol driven. In limited amount of time and well prepared, they moved to exactly the important issues to address the case. And usually, this is where we stop. And we conclude from this that physicians in internal medicine know more about hypertension. If we want to train family doctors, we should send them to internal medicine and expose them to the work of the physicians. Now, understand me correctly, I have nothing against and all in favor of stronger links between internal medicine and family medicine, but not for this reason. What we overlook here is what happens when physicians in internal medicine got a case of uncomplicated hypertension. Immediately they started more explorative, more time, and they kept on looking for the complications that were not there. And this gives us a very important aspect of performance of doctors. And the same must be true for nurses, for midwives, for all the other members of the healthcare team. How the environment in which we work dictates how we work. And in primary care, where the norm is uncomplicated hypertension, and where we deal with early diagnosis, the performance of doctors is different from the hospital center. And I think it is better to pay for family doctors exploring cases of complicated hypertension and spend more time and money there than having physicians in internal medicine exploring cases of uncomplicated hypertension and spend all the money on looking for the complications there. This is because of the importance of training and facilitating doctors in the environment in which they work. Let's move to my second example. And this has to do with, in fact, the question, does person-centered or patient-centered medicine really matter? It's a big issue. There's a strong movement for it. People are in favor of it. But does it matter? And my study comes from a study done by a group of Dutch psychiatrists. So it's unsuspicious evidence from a group outside family medicine. And initially they were interested in the performance and the competence of family doctors in treating depression. And they related their competence to outcome of care. And this competence, they had defined the ability of the family physicians to apply care in accordance with the prevailing guideline of depression. And they more or less split their group. The 50% who followed the guideline closest compared to the 50% who did so the least. And how did that relate to outcome of care? Lo and behold, and I put it a bit in the black-white, but those who followed the guidelines, who were the most competent, had the best outcome. Now, that was all nice and fine, but what made this study exciting was that the researchers had not only looked at competence, but were also interested in the empathy factor. And empathy they defined as the quality of the doctor-patient relationship. So we got, in fact, 4 different modules. Those who were able to follow the guideline with and without a good doctor-patient relationship, and those not following the guideline with that. Now, how did that relate to outcome of care? And I will build it up from bottom to top. First, looking at the family physicians who did not follow guidelines, didn't have a particularly good relationship with their patients. One may wonder what they're actually doing, but not particularly good performing in treatment of depression. But I think the second variant is a more interesting one. A couple of you must be aware of this group of doctors that will say, well, don't bother me too much about guidelines. I have such a wonderful relation with my patients. I know them so well. I know exactly what's good for them. Well, it doesn't help them in treating depression. Well, the next is also an interesting group. This is what I would say, this is more the no-nonsense doctor. This is the, I'm a doctor. Don't bother me about all these behavioral things. I know my skills. I have my clinical knowledge. Well, it doesn't help in depression. And the bottom line of this, where do we have the good outcome? It's in doctors who have skills and have a good working relation with their patients. Clinical skills are vitally important. But if, and I think this is a very important type of study, it only works when it is embedded in a working relation of trust between patient and a doctor. And again, that relation is important, but it only works in competent doctors. And this is why the patient-centeredness is so essential part of the whole structuring of medicine. I did share with you the study of 1994 of Barbara Starfield. I would like to share a bit of the further evidence that she has provided of how important primary care is for population health. And the problem is we now have built quite a knowledge of that primary care is effective, not only financially. A recent analysis of Starfield has looked at primary care density, family physician density in the United States related to health outcomes. Where primary care density is highest, the life expectancy of the population is highest. The number of early diagnoses of important diseases is highest in an environment, in a population where primary care is best accessible and available. And interestingly, from her data, subspecialty density works the other way around. And not only life expectancy, but also in early diagnosis. And that's coming back to my first example of the epidemiological setting in which doctors perform. Our problem is that we do know this, but we don't understand particularly why. And the fact that primary care, the generalist, provides best care is going counterintuitive. And we need to know better why primary care is so important, what the mechanisms are. It's not just any primary care doctor can be the key to effective population health. There must be ways of further improving it, and that is something much ahead. But I think, to share with you a number of hypotheses, it must be somewhere here in the medical generalism, focusing medical care on an integrated approach to all health problems, all stages, in all individuals, and based on people's needs. In the community orientation and taking into account social determinants and focusing on the social structure, the family structure in which patients live. and the personal side. Continuity in person, continuity in time, integration. And to rephrase a little bit the challenges we're facing, although this is the knowledge, and we know that integrated primary care is the best solution, even in recent developments in health aid, we see that there is a tendency to structure aid on single issues. HIV/AIDS in Africa is one of the strong examples. Malaria, but also in developed countries, COPD, depression care as a standalone. This is one of the reasons that although integrated care is where the science is, it looks like organizing it in a vertical way is much more sexy. It's where the money is. And in response to this is why Wonka, together with a couple of other organizations, is urging to seek a combination. Now, there is money going into countries that have desperate health needs. Can we make best use of that investment by channeling HIV/AIDS care in Africa through primary care and set aside a little bit of the huge amount that is coming into that part of the world by investing also further in primary care. 15% of all that money would be a huge contribution to healthcare in Africa, 15 by 2015. Okay, that was a little bit of an aside. This is an advertisement of Wonka's work. What I think my presentation has brought the need for integrated analysis of the functioning of healthcare. Our classification of primary care is the first classification that takes classification outside and beyond the diagnosis into the whole process of care. And I think that is what we need. We need to understand what makes primary care more effective to continue making and working on more responsive, better health care. But in conclusion, I think it is truly now more than ever. Primary care matters. It saves not only money, it saves lives. And it promotes a better population health and better functioning of the healthcare system. That is why it is so important. We're still hampered by the fact that we know the core concept, but we should know more about the actual mechanisms to further improve it. But a contribution it will make. We need to promote it, to train doctors. It's not an art, it's something that comes by training, hard training. And although there's a lot of research to be done, there's no need to postpone action, because I think healthcare reform is not just a one-off. It's an ongoing process. All the time we have to rethink whether what we are doing is responding in the most effective way to the ever-changing needs of our populations. Thank you very much.
Thank you, Professor Chris Van Wiel. Now it's time for tea break. Tea and refreshment will be served at the reception area outside. The conference will resume 15 minutes later. Thank you.
齊咗先。5張。差唔多啦。台下俾 MC 係嘛？One two one two. One two one two. Wait.
Testing. Testing. What? Testing. 1 2 testing. Testing 可以大啲。Testing 可以大啲。Testing 1 2上翻少少。Testing 可以細啲。Testing 細啲 fit 啊。Testing 細啲。Testing Testing. 1, 2. Is it free? Testing. Testing. 1, 2, 1. 都有 free 啊。Testing。你寫拉低啲唔好咪。Testing. Testing. 1, 2, 1, 2。都有啲喎。Testing. 1, 2。Testing。OK， 但細聲少少，可以大聲少少。Testing。1, 2。差唔多啦。Testing。1, 2。可以大啲。Testing。Testing。1。Testing。Testing。Testing。Testing。依啲得啦。阿坤 keep 咪。Testing.
1 2 1 2
Testing. 1 2. Testing. 1. Testing. 1 2 1. Testing. 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 1. Testing. Testing.
One, two.
좋아요.
That's working, is it? Yep. Yep, that's working. So, shall I turn it off?
So how about I move it on? Okay, so how about I try testing 1 2?
1 2 1 2 1 2. That's working, isn't it?
So we'll move it in the control room. So there's no voice will come out from the mic.
Okay.
即係我講我冇咗佢。
你要。
So I'll just leave it in my pocket.
Okay.
Thank you very much.
Testing 1 2.
1 2 1 2。
有啦。會留一個。喂，將呢張凳揞到啦。係呢個可唔可以等爭住？我爭住，我爭住就得㗎。冇好重啊嘛。唔該，對住唔該。 你講完就坐啦，有3個。上到。會開始嘅，開始嘅。Ladies and gentlemen, welcome back. May I now call upon Professor Nicholas Mays to give us a presentation entitled Reforming Healthcare Systems, Relevant Insights from the United Kingdom and New Zealand. Professor Mays, please.
Thank you, and thank you very much for the kind invitation to visit Hong Kong and to give some reflections and remarks on 2 other healthcare systems that I'm involved in. And thanks for all the hospitality that I've received so far. I'm going to, in this presentation, talk about 2 sets of changes in the primary healthcare system of New Zealand and the UK. First of all, New Zealand, which on Barbara Starfield's analysis of the degree of primary care development, used to typically be in the medium or middle of the distribution, and the UK, which was always regarded by Barbara Starfield as a highly developed primary healthcare system. And what I'm going to talk about in New Zealand is the development of the coverage of primary healthcare by the public system in the last 10 years, followed by a modest development of payment for performance in primary care. Whereas in the UK, with its long tradition of universal free primary medical services based on patient enrolment with a preferred general practice, there the focus has been very much more in the last 10 years on developing ways of paying for better performance. So here we have in the UK a system with universal free access and based on enrolment trying to improve that performance. In New Zealand, a bit more like the situation in Hong Kong, a system which had free public hospitals since the 1940s, trying to develop its primary healthcare system by expanding the degree of public funding for primary care, but also in the last few years trying to improve performance. So the main focus of my talk is payment for performance in primary care. And I'll try and draw some conclusions and lessons, but my knowledge in detail of the Hong Kong system is limited, and so I'm not going to tell you how to run your system or how to reform it. I'm just going to try and, I hope, produce some insights that you can find useful in the future. If we think about healthcare reform, we're often grappling with these 3 key dimensions, which are often in tension with one another. We have a concern simultaneously about the cost of services, irrespective of who pays, public or private, the quality of care, and how people access services in order to achieve a good set of outcomes. And what I would argue in general is that you need to change not only how patients access services, so the whole debate about financing and coverage, but you also need to think about reforms which change the nature of the services provided. And Chris Van Wiel's presentation showed that really clearly. It matters quite a lot about the balance between, for example, specialist and generalist care. So when you're thinking about healthcare reform, we're not only thinking about finance and coverage, we're also thinking about how can we change the incentives and the reimbursement methods in the system to change the nature of the services, who they're provided by, and where they're provided. So that reform has got to not just think about finance, it's also got to think about the payment incentives on providers. So that's my general orientation. It's both finance and the incentives on the providers that will generate a different kind of health system as well as a change in coverage. So to New Zealand, which was really by the end of the 1990s, with its well-developed public hospital system, concerned about the quality and access to primary care. New Zealand is a country which has a well-developed GP system, but that system had grown up very much outside the public system. And the pattern of funding until the late 1990s was that the public sector subsidized patients on low income and patients who had high needs for primary care because of chronic disease, and children were subsidized with GP visit fees and their pharmaceutical charges. But those subsidized patients still paid very considerable co-payments or user charges. Even if you were in a subsidized group, you probably paid about 60% of the full cost yourself out of pocket or through insurance. And most adults, the vast majority of the population, paid the full costs of GP visits. So we have this contrast. And again, it resonates with Chris's talk between a free at the point of use hospital service with no user fees and, for many adults, a full cost out of pocket GP system. And the interesting thing about the patient fees for GP visits, if you're in a subsidised category, is that above that subsidy level, the fees were unregulated. So the fees vary depending whereabouts in the country you were and how affluent the population was. GPs were paid by fee-for-service, and roughly a typical GP, 40% of their income came from public sources, i.e. these patient subsidies, and about 60% from private, mostly out-of-pocket payment. So that was the situation the government inherited. Lots of concerns about access, particularly people whose income was just above the subsidy threshold, but also about the incentives of the fee-for-service system and the kind of primary care that it encouraged. Essentially, it encouraged first contact, walk-in services, people coming in off the street to any GP and receiving a service, rather than the continuity of care, the focus on prevention that Chris was talking about. And you'll see this. This is from the Commonwealth Fund International Health Survey, Australia, Canada, New Zealand, UK. Just draw your attention to two lines. The take-up of prescriptions, these are GP prescriptions, due to price faced by the consumer. 20% of New Zealanders at this point, this is in 2002, complaining about cost being a barrier. 10% in the UK. Here, could they get usual medical care, i.e. GP care? Over a quarter of the New Zealand population complaining, as against 4% in the UK NHS. So, general view from a number of comparative sources that there were some problems in terms of access, as well as some problems in terms of the nature of the service provided. So we get an incoming government, broadly a Labour government, coming in the late 1990s, determined to try and do something about it. And it pursues a strategy with a number of distinct elements. On the organisational side, it developed what they call primary health organisations. These are non-governmental organisations which are paid a public capitation fee, i.e. a per enrolled member of the population fee, to provide primary care. They contract with the GPs who are still in the private sector. So these are not-for-profit NGOs with significant community input to their governance. And at this point, they introduce PHOs, and it's entirely voluntary, both in terms of whether patients want to enroll with PHOs, but also whether doctors and other primary care providers want to enroll and affiliate with the PHOs. Of course, the catch is if you don't enroll, then there's a whole tranche of new money that you can't access, regardless whether you're a patient or a practitioner. So the role of the PHO is then to subcontract with GPs, midwives, and other private practitioners in primary care to provide essential primary care services. Because at this time, the second strand in the strategy is a big increase in the public, i.e. tax funding, going into primary care. The government essentially wants to deal with some of the access problems and some of the financial barriers by increasing its share of the funding of primary care. So primary care remains controlled and provided by private practitioners who own their own businesses, but the share of public funding is likely to increase during this process. So the government essentially wants to alter the incentives that are working at the level of the practice and move to some extent from a more fee-for-service culture to one that uses more capitation funding. So from a practitioner's point of view, you need to affiliate with a PHO in order to receive the additional cash. Likewise for patients, if you want your user fee to go down, you have to enroll with a PHO. And the idea is to shift the system away from individual targeting, using subsidies, towards not quite a universal system, but a movement in that direction. But at the same time, practitioner co-payment still remains in the system. The medical profession is very determined to hang on to its ability to levy a fee in New Zealand. But that's limited now by local negotiations between the health authority, primary health organisation, and then the practitioner. So what's happened in this world of enrolment, capitated primary health organisations, and an increase in the public share of funding? I'm involved in an evaluation that's ongoing in New Zealand. We're looking quite simply at the effect on user fees, but also on consultations and who's consulting and who are they consulting. Very clearly and not surprisingly, the average GP visit fee, particularly in what they call higher need practices, which received a higher capitation, has fallen in all age groups in the period since 2001. These data run up to 2005, and we're in the process of updating the analysis at the moment, particularly for the over 60s, because if you remember, children were protected under the previous system, or at least partially protected from the cost of GP visits. And in the lower need practices, which received a lower amount of capitation, there were more modest rises in fees, but again, the fee increases were much lower than they would otherwise have been. And again, not hardly surprising, but in line with what the government was trying to achieve, GP consultation rates have actually increased in all age groups, particularly in the higher need practices, and particularly among older people, which I think is quite surprising, because by and large most of those people were protected under the previous system. But the important thing was, even under the previous system, they were still paying quite substantial user fees. This is actually really quite a large increase in utilisation, roughly somewhere between 1 and 1.5 extra visits per person per year. The research we've done suggests that this is basically a whole series of needs that were unmet under the previous system. Even among people who could have afforded to make a GP visit, they were actually deterred by the upfront cost. And you saw in that survey that I showed earlier on some of the background to that. What was also interesting about the move towards a greater share of public funding, and the fact that most of that funding comes through capitation. I don't know whether you can see over these microphones, but a greater proportion of the total consultations were with nurses. So what's happening here, as you change the payment method for family medicine or primary care, and if particularly using capitation, you're also making better use of the nursing workforce. New Zealand has supported the training and introduction of practice nurses in all GP practices, but up to now they've been hugely underutilised because of the financing arrangements. The fact that in order to claim a public subsidy, a patient had to see the GP. Therefore, there was nothing really for the nurse to do. Under this capitated system, of course, the practice looks quite differently at the use of all the staff in the practice, and it becomes just as important for them to use their nurses, who then become a resource, as to use their GPs for relevant care. So that just shows graphically very, very big shift in a really rather short period of time. The brown bar represents the proportion of nurse consultations, which has continued to rise. And as we know from the evidence, the literature suggests that patient satisfaction, patient experience with nurse consultations in well-organised primary care is extremely high, and in fact often higher than interactions with GPs. So that's the background to the financing and the coverage reform, if you like. But during this process, in this 4 or 5 years of rolling out an increased share of public funding through capitation, it's also become increasingly apparent that the variability in the quality of general practice care in New Zealand is just as great as it ever was. So if you just improve access and coverage, all you do is kind of raise utilisation. You don't deal with variations in patterns of care, nor do you deal with variations in quality. You just raise the overall ability or probability of access, which may have health benefits. But the question is, the government's put quite a lot of extra money in. How is it going to ensure that it gets greater value from that resource? So what we're seeing from 2006 onwards is the development of a performance management program. Unfortunately, New Zealand, small country, limited resources, research really quite costly, as costly to do the research in the UK as it would be in New Zealand. This program hasn't yet been formally evaluated, so I'm not going to be able to show you any outcomes. I'm just going to describe to you how those capitated primary health organisations are being encouraged to, in turn, encourage their practitioners to focus on important areas of quality. And that, as I say, that's because of concerns about variations in quality, but also variations in resource use. And to sort of supplement the incentives in capitation. The incentives in capitation payments are pretty blunt and indirect. And here's an example of the sort of variation people are concerned about. This is the Maori population, i.e. the indigenous people of New Zealand. As the proportion of Maori in each PHO population increases, so as we go from left to right on the horizontal axis here, the number of tests per year, these are routine lab tests carried out by GPs, is actually lower as you go to the right-hand end. So this is entirely contrary to what we know from the epidemiological data about morbidity in this community. You'd expect the line to go in the opposite direction from bottom left to top right, suggesting that there's unmet need, but also some issues about case identification and issues about the quality of primary care received by the indigenous population. Very common pattern in many countries. Minority groups possibly being underserved, other groups perhaps being overserved. So this is just one example of many of concerns about variability. So the aim of this program is to improve the health of the population enrolled with a PHO, to reduce disparities in health outcomes through supporting clinical governance, in other words, the clinicians in the PHO becoming responsible for the quality of care, and to support continuous quality improvement. And the PHOs volunteer for this scheme. There's some money behind it, but again, it's a voluntary scheme. They don't have to join the performance improvement program. Main elements in this program: series of performance measures in the clinical domain, expenditure domain, and some process domains to do, for example, with ensuring up-to-date information and the use of a single health identifier for patient records. And then once the performance has been assessed, there's educational review and feedback. So that's the kind of developmental side of the program about relative service use and the clinical quality against some of these indicators. So feedback is given to the PHO, and then individual practices within the PHO can also request feedback on their own performance, benchmarked against the PHO, benchmarked against the PHOs in their region, and benchmarked against the national average. And then the pay for performance element, which, if you like, is perhaps a less important part of the process. Small amounts of money are then allocated to the PHO if the PHO has met these national performance standards. And the way the payments are made is the further you are away from the national standard, the more you have to improve in order to get any payment at all. So the payment is for improvement, but it's actually trying to say to people at the wrong end of the distribution, you really have got to, these are national standards, and you've got to get above the basics. Otherwise, we're not going to give you any payment at all. So it's quite a tough regime, but only quite small proportions of the PHO income are at stake in the system. This is just to show you the range of indicators. At the top there are the clinical indicators that were used in the first round of this program. A variety of screening, vaccination, some things to do with quality of prescribing, and a range of other indicators. And they count for about 60% of the weighting given to each of the indicators. A range of short-term or interim process measures, as I said, to do with quality of reporting and completeness of information. And then another 30% here for really unexplained variation in resource use. So basically trying to say, is your resource use in line with what we'd expect given the needs of your population? And if you can't explain it and it's diverging in the wrong direction, in a sense, you would get penalized. So here's a typical report card that comes out of this particular system. And the point to make here is this is in the New Zealand environment, of well-developed private general practice, but relatively unorganised, certainly by UK standards. So this is quite radical to actually have information on this kind of a consistent basis. And you'll see here's the number of cervical smears in a year, 622,000, coverage rate of about 50%, pretty poor in this age group. And here's the local health authority, the District Health Board performance, a PHO, a family doctor within the PHO, and then a range of other medical practices, again, within that PHO. So the idea is a very simple one. Information can be used by these practices, by the PHO, by the District Health Board to try and improve performance. But also at the PHO level, there are some very modest financial incentives. Now, I apologise, I haven't been able to show you the impact of this yet. Anecdotally, there's some signs of convergence of PHOs around some of the performance indicators. Some other points to make about this program, and in a way I'm putting it up in order to contrast it a bit with what's going on in the UK. The payment is made to the primary health organisation, so to the collective of practitioners, not to the practitioners directly themselves. And the other focus is it's seen as not so much a payment to increase the income of the practitioners or indeed the PHO, but a payment to further improve services. So the way the money is supposed to be mostly used is to be planned into the following period's service improvements. So there's only an indirect incentive in this system for individual practices to strive to hit the targets. And there's no formal contract in the New Zealand system between the payer, whether the payer is the government or the local health authority, and the practices. The PHO is an intermediary, but there are no contractual relationships yet in the New Zealand system. There's nothing like the UK NHS contract. And the payments are small. And there are a small range of performance indicators. What I'm going to talk about in a minute about from the NHS is a large number of indicators, a large proportion of money, and money paid directly to practitioners. So a rather more aggressive system in the UK. This is a modest shift in the direction of payment for performance. The final thing about this scheme is that the indicators that were selected, the breast screening, the cervical cytology, the immunisation for flu vaccination and so on, were not chosen very much with professional or patient involvement. They were very much government priorities, if you like, imposed on the system. I mean, they're not unreasonable things, but they're not the priorities derived from extensive consultation. So in New Zealand, what we've seen in the last decade is big reduction in financial barriers. Yes, it does increase use, and it's normally it's likely that that use is broadly in line with population need, as far as we can tell. It's very hard to make that association, but as far as we can tell, it has tapped unmet need. It has also changed the mix of providers, so it's very much encouraged the use of nurses, particularly for preventive activity. So the next challenge that New Zealand faces is improving quality and value for money on an equitable basis, and it's made a very small start with this modest payment for performance programme. But it's been seen as highly acceptable to the PHOs and to most practices. There's been very little resistance to this idea, partly because it's quite a modest scale. But unfortunately, the evaluation, the early signs from the evaluation have not yet been made available. Now, I'm going to pick up the same theme, but in an environment where we've had universal, free at the point of use, enrolled primary care since 1948. So a rather different context, in a sense, somewhere where perhaps New Zealand is aiming for, or partly aiming for, in the next 10 or 15 years. And particularly talk about the quality and outcome framework, which is one component in the current UK GP contract. The GPs have there's a tradition of a contractual relationship between the NHS as the public health system and a set of privately owned businesses, i.e. general practices. The contract was changed in 2004. It's still largely a capitation contract with some elements of fee-for-service, but it also includes this radical innovation of the quality and outcomes framework, which is a payment for performance element in the contract. Paul Chicale, who's an acknowledged sort of world leader, if you like, in quality improvement, does a lot of work for the Veterans Health Administration, said, contains an initiative to improve the quality of primary care. This is the boldest such proposal on this scale attempted anywhere in the world. And I think that is true. In fact, I'm very envious of colleagues who study the quality and outcomes framework, because they're the few UK health services researchers who can always get their papers published in the New England Journal of Medicine. Because the people in the States cannot get enough of the analysis of the quality and outcome framework. And this is an initiative which has been the subject of extensive evaluation, and I'm going to give you a flavour of some of that now. So the objectives, very broad, very ambitious, to improve the general quality of primary health care. So this is in a system of universal provision, well-established, well-developed, strong IT, strong team-based general practice, reasonably good availability and accessibility across the country. But this is the government saying that's not good enough. There's variation in quality. We want to make it better. So the idea is to use this incentive system to actually reduce variation between providers and to reward the best practice. And critically, the idea of the scheme based on evidence. So the theory is that these indicators that people are chasing after have some basis in evidence of effectiveness, and one hopes eventually cost effectiveness. If you look at the indicators in the performance package, it's mostly focused on what you might call secondary prevention in primary care. So it's the identification, recording and management of risk factors for chronic disease. Complex design, this is again another voluntary scheme, although about 98% of GPs in the UK are now involved. It rewards practices for the quality of clinical care and the organisation of care. And in contrast to that New Zealand scheme, you'll notice roughly 25% of the income of the practice depends on hitting some of these quality targets. So this is a very highly geared, highly incentivized payment for performance system. In the US, it's rare for schemes to get above 10 or even 15% of the income of a particular provider or particular practitioner. So this is a highly geared scheme. Practices are awarded points for achieving certain standards, and interestingly, they're not awarded points primarily for improvement, but for getting through a hierarchy of improvement standards. There's roughly 1,000 points available each year, which equates to currently, I think, about £150,000 per practice. So again, it's a very substantial amount of money. The indicators are in 4 domains, and there's over 150 indicators. Again, very, very ambitious, a huge data collection process required to do this. 65 or so clinical indicators, a range of organizational indicators, and then some indicators for so-called additional services, so beyond the basics of primary care. And also, again, interestingly, and very much in line with the Labour government's views about how health services should be improved, quite a lot of indicators relating to patient experience. And a critical piece of the design, and one of the things that I think makes this scheme worth a lot of attention, is in order really to get clinical support and buy-in and to avoid inappropriate care, the system of exceptions reporting has been built in. In other words, to try and reduce the incentive that you refuse to enroll or you try and disenroll patients who are difficult or high need or who might be costly, you, the practice, can actually take out of the numerator and the denominator of the calculation patients who refuse to be screened or refuse to be followed up or don't attend, patients who for very particular reasons a particular intervention would not be appropriate, for example they're terminally ill or something like that, and newly registered and newly diagnosed patients, or patients in whom you've already reached the ceiling in terms of quality, that you're already prescribing in the optimal way, and therefore there is nothing to be gained. Those patients can be removed from the system. And there was a lot of debate about this. I think it was one of the key features that made this scheme more acceptable to general practitioners than some of the other schemes around the world. This is just to give you some idea of the range of mostly long-term conditions. Again, very similar to Chris's list of the sorts of things that GPs and their related teams can work on effectively. These are the areas of the clinical indicators. And here's an example of one clinical indicator. I'm not going to go into the 156. As an example, the percentage of patients with coronary heart disease in whom the last blood pressure reading was less than or equal to 150 over 90. And that acquired 19 points. So you'll see they focus on sort of secondary prevention here. And in terms of how this turns into resources, you get a proportion of the point score in a direct linear relationship to achievement between a minimum of 25. If you're below 25%, you get nothing. And if you're over 70%, you don't get any more. And then you get a linear relationship between those 2 points. How did the practices respond? Well, this whole thing was part of a complex contractual negotiation which was supported by about 70% of the GPs who were balloted by the British Medical Association. It was a voluntary scheme, but by the 3rd year, almost all the practices in the country had opted in. And what we saw was increased activity in the areas incentivized, much more income coming to practices. I mean, this was part of a broader investment in the NHS. More staff recruited, again, particularly nurses, and some evidence of uncovering unmet need, again, even in this universal system with free at point of use, with some knock-on effect in terms of hospital costs in the rest of the system. And, interestingly, a very, very high level of achievement. Roughly, well over 90% of practices currently are achieving almost the full the practices are achieving roughly 90 to 95% of the full number of points. So there's been a lot of debate about whether the system is too easy and whether the government's actually paying for things that were already happening. But of course, the other side of this is that if you want GP buy-in to the system, if you make it too hard, they won't come. They won't get involved. And what's interesting about this system now is that the actual indicators are being gradually renegotiated to get into areas perhaps where practice isn't so good. The GP leaders argue that this demonstrates how good UK general practice was, and maybe it is. So it's an interesting dynamic you've set up. In other words, you've got a highly acceptable scheme, quite a lot of money, but also the scope to renegotiate as you go. Now, like all good pieces of public policy, lots and lots of concerns, lots of debate about whether it's a good thing. The two main areas where we've got some evidence but also concern, one was the idea of gaming. In other words, people would basically fiddle the system. You know, the question is, are general practices fully altruistic? Well, no, they're altruistic to some degree, to some other time, depending on the incentives. And then the second one was a concern about the impact on the quality of care, saying, you know, how well do these indicators actually reflect quality of care? How much of this are we actually paying people just to do better reporting, provide better information? And how is this going to affect quality? Is there going to be divergence or convergence around quality? And this other point about, well, if quality is already improving, why pay more to get something you're already getting? So I'm going to look at both of them very, very quickly. The exceptions reporting, which was the main area of gaming, the concern was that if you give people the right to remove patients from the numerator and the denominator, that they will do this to a huge degree, and essentially they'll undermine the system. Well, what this shows from recent data is that roughly only, on average, the median rate of exception reporting is about 5% of patients. Okay, there's some practices here which are excluding routinely about 15% of their patients. They tend to be practices serving refugee populations, large numbers of homeless people in cities in the UK. So, crude message from that one, not a big problem. There's also some evidence, if you're worried about gaming, of high-performing practices that go well beyond what they need to get the maximum points. It suggests a degree of altruism or that they don't even know what they're doing. But it does suggest that gaming in that sense of just reaching the target and no more isn't such a big problem. On quality, we're lucky we've got an independent study based on case note review of the quality of management of some chronic conditions, which has been going on for the last decade and which predates the introduction of the new contract and the quality and outcome framework. And this is in a representative sample of English practices reviewed in 1998, 2003, just before the QOF came in, and 2005. And what this shows is, yes, a continuous improvement in quality after the QOF, and yes, despite the increasing trend before, but that the rate of improvement has accelerated in the post-QOF period for two of the three conditions that they've looked at in detail. So this is independent of the QOF data itself. This is case note review. This isn't just about how well have you reported and recorded your blood pressure, but actually what's happened to the blood pressure. And a number of local studies that corroborate the findings. So this just highlights that graphically. You'll see here, this is coronary heart disease care, where basically what you've got is a very slight increase in the gradient of improvement for coronary heart disease care over time, but very noticeable kink in the line here around the time of the introduction of the QOF in terms of this measurement of quality, which is a sort of multidimensional case note audit, which was developed before the QOF was developed. So again, it's an evidence-based audit of the quality of care, but not one that's derived from what people put into their QOF returns that go back to the government. So I think that provides some indication, yes, that care was improving anyway. Well, that's probably a good thing, because if care wasn't improving, you probably wouldn't get the cooperation of the general practice community. You've got to push it an open door. Don't push it a closed door if you're a policy maker. But you do get some acceleration of the rate of improvement. So this leaves this question of the distribution of performance. What's happening to the distribution? Because obviously the NHS in the UK is obsessed with equity of access and equity of outcome. Probably more than any other health system I've ever come across in the whole world is equity and obsession. And what recent research suggests is that, yes, initially in the more deprived communities, the QOF scores were lower, although the differences were quite small. But there's clear evidence of catch-up, if you like, in the poorer performing practices in the less well-off neighbourhoods. There's evidence of catch-up. This rather messy graph shows the first 3 years. This is year 1, year 2, year 3 of the QOF. And what you see is the distribution of scores across deprivation quintiles. So this is year 1. You see quite a big gradient of scores with poorer performance as you go to the right-hand end, the more deprived communities. And then you'll see this thing gradually levelling off. So here there's almost no difference in the average performance score, and the distribution, you'll notice, the variation has actually narrowed over time. So you're seeing convergence, but you're also reducing the number of sort of extremes in this distribution as you go towards the right. So again, very rough and ready kind of data, but suggesting that concern about if you put strongly powered incentives around payment for performance, will you penalise people working in tougher neighbourhoods, in more difficult communities? Well, the answer is no, particularly if you've got some capability at this end of the distribution to make exceptional reporting and to exclude certain kinds of patients. What have they done to actually make this happen? Well, changes in practice organisation, particularly more systematic care, more use of protocols and guidance, better record keeping. I mentioned much more use of nurses. If you like, crudely, greater managerialism at the general practice level, which of course sets up some tensions in the practices, and there's no doubt about that. In fact, what's emerging in the larger general practices is those who, in a sense, run the QOF and those who are supervised and under surveillance to improve the QOF scores. So you've got a kind of group of clinicians who do the management and a group of people who actually do deliver the QOF points. It's also in the context of a very big investment in the past in information technology in general practice. So the ability to capture and then return this information in order to get paid is based on about 25 years of investment, such that at the beginning of the scheme, almost all the GPs were highly computerized for all their clinical interactions. And I've mentioned the workload for nurses as well. So the QOF, in a sense, a revolution, an innovative world first, an obsession really of the Americans. They're always coming over looking at the QOF. I think most importantly in the UK context, it's established the principle of payment for performance. It's not the perfect system. The indicators may not be the right ones. They may not be perfectly correlated with improvements in health outcomes. There's a lot of debate about whether too much emphasis is given on reporting and recording stuff and not enough on improving outcomes. Debate about whether there's too much about secondary prevention and not enough about primary prevention, and so on. But I think if you're thinking about, again, in long-term reform terms, it's established the principle, which is probably the most important aspect, and the idea that a substantial amount of what people are paid to do should be relating to some evidence that this is likely to benefit the patients and the population. It does show that financial incentives do contribute to improved quality, and they don't necessarily have to produce increased disparities, albeit this is within a universal healthcare system. And in fact, the evidence is it may well have reduced inequalities in care. It does show that it's critical to incentivize valuable activities, because it's quite clear with a scheme like this that it will affect what doctors and nurses spend their time doing. So you've got to choose things that you value highly. It does change interprofessional relations, but there were a set of major risks that don't seem to have occurred in quite the same way. There was a great concern about the loss of continuity of care, of biographical medicine, of holistic care. What seems to have happened, at least in the British environment, is that the docs have continued to do that kind of difficult work, the diagnostic work, the dealing with complex morbidity. And nurses have tended to specialise in the risk factor management and the, if you like, the pursuit of the QOF points. And there's been a sort of division of labour within the practice environment, which has kept both of these elements, if you like, of primary care alive at the same time. So what can we learn? Well, I think what we're learning from these experiments and these developments in services and systems which have really relatively good coverage at the beginning is that improving coverage and access is, of course, necessary for health improvement and for improving the system. But it's not sufficient to improve quality and value for money to the level that the payer may demand or the population may want. Hence this interest in more elaborate and more specific incentives of payment by performance. It does show that payment by performance incentives are complex. The targets you pick up must align with the values and priorities of providers and increasingly also of patients. So it's no coincidence that the areas covered in the UK QOF were largely based on reviews of evidence undertaken by clinicians themselves and clinical researchers. And it was quite difficult, even for the most sceptical GP, to argue that these were irrelevant to improving health. Because it's very important, obviously, in these systems to avoid harming the intrinsic motivation of professionals to do a good job. So far in the UK, at least, people have tried to look at this qualitatively. There's not much sign that we've sort of driven out GP altruism by paying for performance. But that's obviously something you continuously need to monitor in order to make sure, in Chris's sense, that you get the clinical competence, the use of the algorithm that may be driven by the financial incentive, but you also get the empathy and the continuity of care and that relationship. You need both and. It's not an either or, unfortunately. The other thing that I think we're learning is that, and the contrast between the UK and New Zealand, the importance of doing pilots and evaluations and getting some baseline measures in place before you initiate these schemes so that you can alter the detail of the design, because the devil does lie in the detail. What are you going to incentivize? How much? On what basis? For which sorts of patients and for which kinds of practitioners? Lots and lots of decisions there. And one of the things that the UK should have done more of and didn't, it didn't really work out what was the minimum it needed to pay to get the kind of improvements it wanted. It's probably overpaid for what's happened in the UK. But at the time that the scheme was introduced, money was not a problem. Well, it's a bit different now. So I think if you're designing pilots, what you'd be saying is, let's have some prototypes. Let's see how much do you need to put into the pot in order to change the management of hypertension or whatever it might be. Budget for higher than expected performance, so particularly if you've got competent primary care providers, they're likely to get their act together quite rapidly if you put money on the table. Try to avoid paying for improvements that are already happening, and anticipate the negative effects. Anticipate a degree of gaming and a degree of subversion of the system. In fact, if there's no gaming going on, there's something wrong with your payment for performance system. You've got to expect it. It's a sign that the incentives are being taken seriously. The job of the policymaker, therefore, is to minimize that, working closely with the professionals. Thank you very much.
Thank you, Professor May. Please take a seat on the stage. Ladies and gentlemen, we will now start our panel discussion on the topics covered this morning. Our director, Dr. Donald Lee, will be the moderator, and we would also like to invite the following discussion to join the panel. Professor Sean Griffiths, Professor Chris Van Wil, and Professor Gabriel Leung, please come up to the stage.
Hello. Yes. I think we'll start right away. I'm sure all of you agree that we have some excellent presentations which set the stage for further discussion. And I'm sure all of you have lots of questions to ask. But I think what we'll do is we'll have some discussion amongst the panel, and we'll certainly leave some time for questions from the floor. Now, to start off with, as our secretary said, the undersecretary is here to answer questions, but then he's not going to answer questions yet. We're going to ask him to highlight some of the healthcare reform that's been happening in Hong Kong, especially I think in the delivery system side, since this morning's session is focused more on this, and we've had inspiration from other speakers as far as the importance of primary care and also incentives and so forth. So Gabriel, maybe would you like to start?
Thank you, Donald. And my job is to answer questions that are not so much dealing with big principles. My job is to tell you how we're going to get to what the Secretary outlined this morning. As he pointed out in the keynote speech earlier today, he said, look, we've just released the report to the first consultation document. The report says we've been able to make some good progress in bringing Hong Kong people forward. What we've been able to do is to focus the discussion on not whether we need to change, but how and when we need to change. The first stage consultation very clearly told us through the 4,900 submissions from both organizations and individuals, as well as the more than dozens of polls that we ourselves have done, but also civil society and academics have done, independent of government. What these views have told us is that, look, everybody agrees the present system is not sustainable. We're not just talking about financing, but also about the way we deliver services to the population. So there's very strong, predominant view of the need for change. Then the second thing is, we asked, well, could we proceed with some aspects of this change first? And should we? And overwhelmingly, the public told us, as well as all the major political parties, look, please go right ahead with all the service reforms you've outlined. And these include, of course, primary care, which has been the subject of discussion for the better part of this morning, but also the electronic health record, the increased public-private partnership models, and strengthening the safety net of the public system. So these things, we've got a very strong mandate from the public to press ahead with. And that is what we will be doing and what we have started to do already. Then on the question of supplementary financing, the Secretary told you, and I'll give you some numbers, that since the financial tsunami in December, and most recently just a couple of weeks ago, looked at some poll numbers, and consistently 70% of the people say, look, we realize that financing, or supplementary financing rather, is not sustainable in the long term. You should keep talking about it and keep discussing it and keep the momentum going. Very consistent, solid 70% unqualified support. An additional 10% or so would say, if you agree not to implement any changes before the economy takes an upturn again, then please go ahead and do it. So a solid 80+% support if we're not going to make any changes or implement changes before the end of this downturn in the economic cycle. So we will keep talking about that, but that's not the subject of this panel. The subject is primary care. So we've got this public mandate to take it forward. How are we going to do it? The Secretary has already held a first meeting of a working group on primary care, which he has convened to include most, if not virtually all, of the stakeholders, including patients, including professional groups, including all the major stakeholders. That first meeting has taken place, and subsequent to that first meeting, we've all agreed that there are 3 key areas we should be looking at. One is, what is primary care? You heard from the Vice Minister and Party Secretary this morning. In fact, the very first thing he said was, all reform efforts have to be contextually specific. You have to look at the context and the setting, and therefore, whatever changes you make have to be fit for purpose for that particular context. So what is primary care in Hong Kong's context? That is the first major task. And we have a task force looking specifically at that question. What is primary care? What is a possible conceptual model or a couple of possible conceptual models that is fit for Hong Kong's context? And that context is primary care, or rather ambulatory outpatient care, is predominantly provided and has been for decades by our private sector colleagues, well over 70 to 80%. That proportion fluctuates depending on the economy, but the vast majority of such has been provided for in the private sector. So we can't import the NHS or the Dutch system or the US system or the Canadian system or any other system wholesale and say, look, this is what we're going to do. That's why we've got a special task force which met on Wednesday for the first time to look at what is primary care and what are some key conceptual models we should be pursuing. Then the second thing is who? Who is a primary care provider? Who should be the beneficiaries of primary care provision? So that we've got the Primary Care Directory Task Force, which met for the first time yesterday afternoon. And that group is tasked with the aim of identifying a team of people who, again, would be contextually specific to Hong Kong, that is fit for our purpose. How do we get this team of people looking after the health of our population? And then finally, it's the how. Once we have an idea of what primary care is for Hong Kong, who is going to provide this kind of service, then we need to find a way to deliver it. And that's the third task force on delivery models. So again, we're not ruling out possibilities of more than one model, because in effect, we already have multiple models of delivery of primary care or first contact care in Hong Kong. So what we're going to do is to have the task force advise government, look, these are some possible ways that you could deliver, incentivize high quality primary care to your population. And this is what you should be doing. And amongst many ideas, we have mooted the idea of community health centers. This is something that the mainland has had for a long time. We have had for quite a while in history. Decades ago, if you remember, we used to have all these polyclinics. The UK is pursuing these polyclinics. Ara Darcy, who is my counterpart in the UK, has been pushing that in the NHS. And he'll be coming in May at the HA convention to talk about that. So can we find a way of delivering these services specific to community needs and find a way to enhance and promote primary care locally? So that's the task that we have set ourselves, and I very much look forward to learning from all of you here today as we try to brainstorm and pool ideas together. Thanks.
Thank you, Gabriel. Very clear directions. Before I ask our overseas guests to comment, for example, on our direction, may I first ask Professor Sean Griffiths, who's the head of the School of Public Health of the Chinese University, and also actually one of the conveners of the task force, and has been involved in healthcare reform, including our Bohemia study on healthcare reform, to maybe supplement on what Gabriel has said.
Thank you, Donald. Yes, I'm chairing the conceptual task force, so please send us your ideas, because we have some, we have quite a lot, but we need to know what people think. I don't want to take the time from the general discussion. I just want to comment on a few points and re-emphasize some issues. The first is on context. Gabriel talked about context, and I fully underline the issue that each healthcare system is unique, but we must learn from each other, which is why we've got the international exchange today. So it's very easy to say we're different, but we need to learn. So I just would share that thought with you. And the other thought that came through very clearly this morning, particularly from Minister Gao, was that this is a continuous process. It's a long-term process. And both he and York Chow said Rome isn't built in a day. And I think we need to remember that. This is a long-term, continuous process. Why healthcare reform? Healthcare reform is not just about saving money. It is about creating a sustainable healthcare system, but it's about looking at the population of Hong Kong. We're living longer. And if we're living longer, let's live healthier lives. Let's actually help other people to live healthier lives, to be disability-free in the community. And that's a key role for primary care, to keep people healthy and not just to provide sickness services. So we need to see a shift in not only our investments, but our attitudes. So if we want to see an investment shift in our attitudes, we need to think about whose attitudes? Well, one of the groups we need to think about are the professionals themselves. And as someone who works in a medical school, there's a big challenge to us and to my colleagues, and many of whom are in the room. How do we help promote prevention in our clinical practice, including prevention when people are in hospital? A challenge. How do we focus on prevention? Not only how do we focus on prevention, how do our patients think about prevention? Hong Kong is not a very active society. The DH does surveys, and we know that 80% of our population come in the physically inactive, okay? Inactive. So 80% of you are not active enough, roughly speaking, all right? take that away. That's what we're talking about. What are you going to do about that? That's a change in population perception, population engagement, and in focus towards prevention. And the politicians, it's not just the health ministers, it's actually the ministers in other departments, such as environment, such as social work, such as education. So we need to think about those things. Very quickly, how are we going to know what we need to do? We need data and information. Professor May's talk was based on information. That's how you can tell whether you've reduced health inequalities in a population. We need information, and our moves towards an electronic patient record are fundamental and important ones in helping us provide information. We also need to think about our attitudes to information and also towards public information, not just data, but public views, and how do we really make sure we play those in to our healthcare system. Throughout the discussions today, I think Chris Van Wiel's presentation emphasized for us the role of science and guidelines. So it isn't just being an empathetic, nice person that counts as being a doctor. It's about actually putting science into practice. And I think, again, there's messages there for us in terms of how do we educate, how do we involve a lot of people in understanding what it is we should be doing, what is the evidence, what are the guidelines, and then, very importantly, a final point, how are we going to know we've made a difference? How are we going to know we've made a difference having done this? And I leave that really as a hanging question. How are we monitoring, how are we evaluating, how are we making sure that we make a difference to the whole of Hong Kong, not just our little sector, not just our practice, not just our hospital. And that involves us thinking about a framework. And that's some of the work that the group on conceptual primary care are doing. How do we actually make sure we benefit? And I think you heard Minister Gao saying, his last point was, and how do we share some of that, particularly with mainland? So there's some challenges for us there, and I don't want to take any more time, and Donald's told me not to, so I won't. And many of you know I can go on forever, so I won't. I will stop here and take part in the discussion.
Thanks, Sean. And before I move to our two speakers, you know, the advantage of being a chairman is I also get to speak. Now, in fact, Sean has brought up the question about attitudes, which is also the key feature of the Bohemia study on the healthcare reform. We thought that the key issue is behavioral changes in three parts. One is institutional, which we are very happy to see government has completely changed in their attitude towards primary care, promoting it, and we can see all the things that Bureau is doing. So that is one major achievement in my mind. Providers change has been very difficult, but all these tasks that we're doing in primary care is also a step towards it. But then that also comes towards incentives, which later on I would like Nick certainly to elaborate on how we can apply that to the Hong Kong systems, for example. Now, the most difficult part in my mind is really patient behavior or health-seeking behavior by the public. This is seldom addressed, and probably even in our present studies and task force work, we may be too focused on providers and rather not really focus on the recipients of care. And in this area, I think education has a lot to do with it. So I think it's really a cross-section involvement, and we really genuinely want to improve our healthcare and reform the healthcare system in Hong Kong. So with this, maybe Chris, you'd like to say something and comment?
Well, I have spoken, so I will be very, very short. But I think the issue, every country has to go through this at its own value, and that's the, it's not only the context. The context in itself is a reason why you cannot simply transplant a good model of primary care from one country to another, but it also needs the commitment of everyone. The whole idea is to have people, institutions, functions serving the needs of population health, and that only goes through the involvement. And critical to that is you work with professionals. Professionals have a professional view, and they know something of what they're working with. So consultation, you have to do that. And probably one of the lessons we are learning that this has to be an ongoing exercise, and we've been looking at it very much as we have a system in place, and then it will take care of all the problems, and that's not true. And my last point, I think it is, the main part now is to bring care to where it can be done more effective, efficient, cost-effective, and that is primary care. But in the same time, I think we are looking also at the increasingly at the limitations of hospitals as institutions. Also for patients who need highly specialized care, the emphasis is on keeping them as functional as possible. And that is something you can only do in the community. You cannot do in a hospital setting. So what I try to say is we need a highly qualitative, high-performance primary care for the work to be done in primary care, but also to be hosting in the future specialist care of small groups of patients that should be treated as much as possible in the community setting with the help of generalists but also specialists. I think that is the process we're facing.
Thanks, Chris. Nick?
You've already heard enough from me as well. I'll be brief. I mean, one's just an observation of something hasn't come through very much, but which was in the background of the New Zealand experience, which was the relative rate of increase of hospital spending versus primary medical services spending in the period of reform. You recall I talked about how the government made a big commitment to increase its share of the public funding of what had largely been privately funded primary care. One way it did that, obviously, was to slightly increase the overall health budget, but it also did it by energetically trying to manage hospital expenditure and basically put quite a lot of pressure on the hospital system to improve efficiency. So I suppose there's a story there that the flavour of the debate about the context here seemed to almost take the hospital system as if it was for granted. It's sort of there, and we have to kind of work around it. That's just a comment, really. My other comment really is about how one pays for primary care. And although the research evidence base globally is not absolutely vast, I think there is among experts an emerging consensus that irrespective of what concept of primary care you have and quite how your primary healthcare team is constituted, that particularly if you're the public payer and you want to pursue a range of desirable health improvement outcomes, you have got to think of I suppose what people talk about as a blended payment model. In other words, you can't just rely on any one of the main payment modalities in isolation. In fact, there's a US health economist called Jamie Robinson, and he came up with a wonderful comment, which I wish I'd written, which was, he said, the three worst ways of paying doctors are fee-for-service, salary, and capitation. And what he meant was all payment methods, particularly the simple ones, or the single type, have a lot of upsides and a lot of downsides. So if you want highly responsive, highly available, 24/7, first contact, acute care, pay fee-for-service. If you want, but that has all sorts of downsides in terms of health promotion, prevention, screening, and so on and so forth. And so that, the implication here is if the government of Hong Kong is trying to encourage primary care, it's really the creative use of contextually appropriate blends and combinations of fee-for-service, capitation, maybe some of the sorts of incentive payments that I mentioned from New Zealand and the UK. But obviously what you incentivize in the Hong Kong context may be very, very different. It's got to obviously be what are key health priorities and also things that you think that patients, the population and the professionals are going to really get motivated to deliver as well. That it isn't just going to be about financial incentives, it's going to be about what they think is the right thing to do. So that's just my general plea. Blended payment.
Thanks very much. I think we have a little bit time left, so we're open to the floor for questions, and Pang Guang will
okay.
give us our house rules.
Okay. We will now take questions from the floor. All participants are welcome to put questions to our panelists. Okay, please feel free to ask questions in languages of your own or of your own choices. You may line up in front of the mic stand on both sides. Those who are watching live feed at the auditorium next door may now come to this venue or submit your questions to our staff. Please limit your questions or comment in 2 minutes. Before asking the questions, please also identify yourself. Okay, please.
I'm Professor Essex Lee, Professor Emeritus Professor of Community Medicine, Chinese University of Hong Kong. I just want to clarify this term, primary care. And I would like to welcome comments from Dr. Leung Kei-Boo about this term of primary care. Because in 1978, the World Health Organization have this primary healthcare declaration, alma mater. Primary healthcare is essential healthcare, available, acceptable, and also affordable by the community with community participation. So our target is not just on the patients. The primary medical care, of course, very important, is part of the element of primary health care, but our target is the total population, involvement of the community. In Hong Kong, we are facing triple burden of diseases, chronic diseases, new infectious diseases, accidents, injuries, and mental health. So I would welcome comments from Grable. Now, in what sense we promote primary care or primary health care? I think we should integrate public health into the healthcare system. It's not just treatment. Thank you very much.
Okay.
Well, I cannot agree more as somebody who is doubly trained in both public health and family medicine. But what I have to emphasize is that the primary care working group has to start somewhere. I cannot emphasize enough that the DH's, the Department of Health's non-communicable disease strategy document is an integral part of our work in primary care. And therefore, in fact, in the working group, or the task force rather, on conceptual models and preventive protocols, we will be specifically looking at NCDs as well as mental health issues. So members around the table on Wednesday were very enthusiastic and all agreed with the integration and proper integration of public health in the way we see primary care. Specifically, how we might go about doing it still remains to be seen because time is early yet. It's only been 48 hours since we first met. So I very much look forward again to hearing comments and also have your views reflected at the group. And of course, this is, how can we have a better year to celebrate Alma Ata than to be looking at its 30th anniversary, and incidentally coinciding with the opening up of our country economically. So we very much look forward to working with different communities, and hence we have this idea of a community health center. So clearly we're not only going to be stuffing these centers with doctors and nurses, but also a range of other health professions to bring about the change that you have espoused.
Sean, I think
I just want to draw people's attention to an article written by Chris Van Weel in The Lancet, September the 13th, I think, which would help you to look at the span from primary to community-based primary care. So have a look at his article. It debates some of these issues because it's a spectrum. And as Gabriel says, it's where on the spectrum do you start?
Before we move on to the second question, there's a related question from next door. I'm sorry. So I think we have to give them some priority. Now, the comment here written is, primary care is a complex entity, diverse and little understood in Hong Kong. Some organization entity is needed to take charge of it and organize it and improve it with time. And this person would like some comments from the panel. So who else but the president of the World Organization of Family Doctors?
All the other panel members. Well, I think it is, the complexity is that it is not just one single person's responsibility, it's a common responsibility. That is where and much has gone wrong in how we have related or not related public health and individual health care, and particularly in a population where population needs are translated into individuals' lifestyles. It's very, very important to relate care to the individual, to embed it into an approach to the population and a response to the population. So I think it is important not so much that there is one person or one institution responsible who will give a dictate. I think we will see a repetition of the old shortcomings and mistakes. It's very important that we, all partners, approach the issue from the same angle, and I think that was the base of your question. How can you make sure that it's the public health interest and the individual providers work hand in glove, and there is where the most gains are to be made. It requires some sort of an orchestration, I think, and who provides the orchestration, I think, is not that important. In the Netherlands, the Minister of Health is inviting the insurance companies as playing the role of orchestrator. I think the test is, will they be the best to orchestrate? And that's the question we have to ask all the time, all the way.
Okay, the gentleman on this side, please.
Pei Chou-Pan, psychiatrist in public service. I've a question directed at Professor Mays. First of all, I think the quality outcome framework, I think, is a very bold and innovative scheme, and I really like to commend the British government for introducing it. As a psychiatrist, well, I can tell you that I recognize this at first instance, right, as a huge behavioral modification program, right? So, but that doesn't mean anything negative, right? It's a totally positive comment on that. But what I want to know is that if we break down the cost of the scheme, right, into two parts, right? One part is used for the innovation, the incentive, right? And the other part is the administrative cost. What is the percentage of money spent on administrative cost? Because I think it actually depends on a lot of monitoring and things like that. The second question is, now, for the outcome criteria, for the scores given, right? We all know that people who belong to different age group, right, may need different outcome criteria. Take, for example, blood pressure and the blood sugar level, blood glucose level, and things like that. And also people who live in different parts of the city, belonging to different socioeconomic class, right? Their conditions may vary, and you have to modify the outcome you can expect from these groups, right? So is there any allowance for that, and how are you going to cope with that?
Okay, thank you.
Do you want me to respond now?
Write a paper, I think it's better.
Sorry?
He said write a paper.
Write a paper.
Yes. The first point about the administrative costs and data collection costs, I don't know the precise numbers, but you're absolutely right. I mean, it is a costly system to administer. By UK standards, certainly, I mean, if you can imagine the number of pieces of data that have to be collected from 32,000 GPs or 7,000 practices is enormous. But again, I mentioned that there had been this big investment over 2 or 3 decades in computerization, but I couldn't tell you the precise numbers. The points about how the clinical indicators moderated or altered, for some of them are age specific, but the other point you were making was about, is there an allowance made for, sort of, as it were, the local epidemiological conditions? And the answer is yes. I didn't discuss it in detail, but when the exception reporting is calculated, it's also related to the likely or the estimated prevalence of particular conditions in particular communities. So if you're working in a community, a high prevalence community, that affects that means that the indicators are moderated in that respect. So there is some allowance taken for working in a more difficult environment. So in both those areas, the indicators are altered in some ways. So some of them are expressed in very specific, age-specific terms, and the exceptions and the calculation of achievement is modified depending on local prevalence.
Okay, we'll take a question from the gentleman on that side.
Joseph Song, I'm a humble physician working as a frontline doctor in the public sector. I very much like to hear today on the healthcare reform. We talk about attitudes, and I have 2 points to comment on attitudes. First of all, I'm a little bit concerned about using money as the only incentive to change the attitude of healthcare providers, because I think some doctors, especially in the public sector, are not just attracted by the funding or the money, and we can always, people can always use their way of making better figures to attract for better money for their institution. So I think I'm not denying that this is one of the important incentives, but we should perhaps consider other things to recognize good practices and give people incentives other than monetary return. On the issue, on the side of the patient, how to change patients' health-seeking behaviors and their attitude, we have in fact done a study surveying the public's opinion on cancer screening. And we found that people in Hong Kong, especially males above the age of 50, the population with the highest risk are actually the one who care their health less. And in fact, there are some attitudes like they don't want to know about it. They know they might have risk of developing coronary heart disease or certain cancer, but they just don't want to know about it. And I think these are the areas that we should target on when we talk about educating people and change their health-seeking behaviors. Thank you.
Well, thank you for your comments. Next question.
Okay, this gentleman. Okay, your turn. Oh, Yang Wei Xin. Okay, okay, lady. Okay, on that side, please.
Thank you very much. 我用廣東話講，我係李明佩 Mavis。我係一個更加 humble 嘅一個護士，我有3點嘅意見，同埋2點嘅建議。3點意見，第一個就係我 support 頭先 Professor Lee 所講 community primary health care 嗰個問題，因為我同政府嘅諮詢文件同埋好多位專家講者所講，都係 primary care。咁我唔知道。Primary care 係指 primary medical care 啊，定還是 primary health care？ 我哋作為護士同埋 allied health 嘅同仁呢，就 very much support 呢個 primary health care。我哋認為單純講 primary medical care 咧係唔夠嘅，咁呢個第一點。第二點同 community building development WHO 嘅 framework 裏邊講咧。Healthcare reform 或 healthcare 嘅 promotion，health promotion 唔係淨係 medical， 唔係淨係周局長嘅事，係成個城市嘅規劃，包括教育啊、housing 啊各方面嚇，包括食水啊、sanitation 啊咁。所以 WHO 嘅 framework 咧，亦都包括咗社區嘅建設，所以亦都可能係包埋民政事務處嚇。嘅工作同埋好多 department 嘅一齊嘅工作，我認為 healthcare reform 喺香港特別講到 primary healthcare 唔能夠淨係周局長一個人孭晒，應該政府要統籌全面嘅規劃。第3點，我作為護士同埋 allied health 嘅代表咧，因為我係呢個聯席會議嘅成，我認為香港嘅醫生公立機構嘅醫生好少，非常之忙，而要包攬晒咁多個 care， 包括埋 health promotion， 包括埋 prevention 係做唔到嘅。 而我哋護士同埋 Allied Health 佔咗咁大批人咧，係 underutilised 嘅。我哋嘅 expertise 可以發揮得好好，而 underutilised。包括我自己喺黃大仙區議會嘅經驗，我覺得我哋嗰啲同黃大仙嘅居民咧，除咗 complain 話唔夠醫院、唔夠去睇醫生難啊，要排隊等好耐之外咧，好多時佢哋嚟揾我哋嘅時候咧，佢哋嘅問題根本唔係 medical condition。以我作為一個專業護士，我好多時已經俾咗好多 advice 佢哋點樣去 self care， 點樣去做好多嘢，已經可以唔需要睇醫生，唔需要加 extra pressure on 嗰個 healthcare hospital system。我有2點嘅建議。第一，我認為頭先好多講者已經提到 nursing 喺各個國家嘅一啲經驗、護士嘅貢獻，所以我建議咧喺將來嘅 healthcare reform 裏邊，呢個 primary healthcare reform 特別係講應該增加一個護士作為除咗教育之外，就係 health counselling 可以做好多其他方面嘅諮詢，減輕醫生嘅負擔同埋成個 healthcare system 嘅負擔。第二，我建議應該設立一個 school nurse 嘅制度，好多先進國家或者係 developing country 都有 school nurse， 因為青少年香港嘅青少年同中老年人頭先幾位講嘅問題咧，都係一樣，青少年嘅 health problem 係好嚴重嘅。咁我嘅意見係咁多，多謝。
OK， 多謝。Okay. The gentleman, may I take your question?
Yes, I'm a community medicine doctor, Dr. Ali. I think I'm going to complicate the definition of primary care because I just founded Hong Kong Chinese Preventive Medicine Association. So this is preventive medicine. I don't know what the definition. Does it include the various things that you have discussed? I want to make a comment about Secretary Gao speech this morning. He emphasized on how China is actually doing their reform as well. And China actually needs international standards for medicinal and hospital practices. At the same time, they also emphasize on the community, which is Chinese medicine, which he mentioned. Now, I think Hong Kong, while we are already connecting with international hospital and medicinal standards and practices, we should also sit back and think of how we can use the Chinese experience in their community work, especially the Chinese medicine. Although hospital authority has already doing some work in that aspect, but I think there are so many things to learn. Now, I would also like to ask a question, put a question to Professor Van Wiel, I think. Yes. Do you include, in Europe or Netherlands, include alternative medicine as primary care in your speech? Because in Hong Kong, we do have something like 16 to 18% Chinese medicine practitioners where the population go to visit, and we do have other, something like natural medicine and things like that. And we really like to learn from the Western world about this.
Okay, thank you.
Chris?
I can give you a very simple answer to your question. In the Netherlands, alternative medicine is outside the official medicine part, so we don't include that. We know that there is a slightly different situation in France, and I think this is typically a context question. And this is something that you have to look at in what it is in the Hong Kong and in the Chinese setting, and don't expect that you can invite a model from the outside to fit here, because this is expectations of your patients, your community, the values in the Chinese world, and they have to be taken extremely serious if you want to be successful in providing healthcare here and now.
But do you expect a future trend, like if you mentioned that France and Germany are already, taking into account of, let's say, reimbursements for acupunctures and things like that. Then
No.
what about the European community? What is their view on this?
There is no single view. This is an ongoing debate between. Every time we say that the mainstream of the discussion is cost effectiveness, alternative medicine is out. If it's what you can make to have a nice insurance package, it will come back on the table. So,
Sean has something
Just,
to add.
just to say that there is a WHO framework for complementary medicine, and you can look at that. There's a grading within it, and it grades all countries. So I think it's worth looking at that as the information base from which to make decisions.
I think before we go to the next question, because Alma Ata was mentioned just now, and Chris would like to say something about that.
yes, I think, of course, what we're discussing here is all, in fact, the outcome of a declaration passed in 1978 in Alma Ata that had a huge impact at that time, disappeared completely, and now coming back on the table. I would like to share a little anecdote with you. When a Wonka delegation was visiting WHO, Margaret Chan. Usually when you have such official meetings, it's all very nice and friendly and telling each other how important we are. Not a discussion with Margaret Chan. We were hardly seated at her table when we were in a fierce discussion, and she was challenging us and saying, well, you doctors, you have obstructed the whole development of health for all and the Declaration of 1978. And I think there's, although I don't think it's true, I think primary care has always been very outgoing for and falling back on the Declaration of 78. There is some truth in it that we have too long let an important policy development and a very important opportunity go down. It's political as well as from the medical profession and from the healthcare profession. So that's why it's such an important reason now to make this a success, and that's why the urgency of it and your timing is so extremely good and well.
For the interest of time, shall we just limit to 3 more questions?
Okay, yes, that's right. Okay, the gentleman over there.
Yes, I'm Dr. George Au. I'm a medical oncologist in private practice. I also have some management experience, having worked as medical director for Blue Cross of California, where I oversee all the high dollar payments for medical technologies, meaning cancer drugs, transplants, and so on. When I come over to this meeting, I really also hope when we look into healthcare reform that we can spend some time on looking at what are we going to do with medical technologies that is coming along within the last 10 years. And I think every government that is giving healthcare would have the same problem. In the field of oncology, we have new drugs that cost thousands of dollars. And whether we should pay for these for the patients or whether it's self-pay, I think that's going to be a problem. Right now, I have patients that are in the hospital in the final leg of their cancer illness. They have to decide whether they want to spend the money on some targeted drugs that will prolong their life for a few weeks, or whether they would save that money so that their children can go to a better school or go to a better university. It's a very sad situation, but it's happening all over the world. And I was hoping that in this conference that some emphasis could be put on this particular issue. I think with any kind of healthcare financing planning, I think we have to look ahead, and I hope that besides primary care, which is the backbone of healthcare, I think if you look at these payments, they're going to break the bank. And sooner or later, the government will have to decide whether you're going to provide for these drugs or rather save the money so that everybody can get the flu vaccine.
Okay, thank you. Okay, the gentleman over there. Over here, sorry.
Thank you. My name is Se Wan Cho, otherwise as W.C. Shea. I'm a sociologist at the Hong Kong Polytechnic University. I cannot agree more with Professor May's suggestion that the best strategy in paying for the salaries of primary healthcare providers is a blended approach. But as we all know, in Hong Kong, primary medical services offered by doctors in private clinics who charge consultant fees as their income. How is the government going to lure them into accepting other payment methods without selling out public interests? Thank you.
Well, first of all, thank you. Thank you, Dr. Shea, for your most insightful dissection of the medical economy of the SAR. However, government is not going to lure anybody. Government works in partnership with everyone, and not just only doctors. So let me try to respond to all these very excellent suggestions, and I don't think that anybody at any time has suggested that government's definition of primary care is restrictive in that it's primary medical care. Let me once and for all dispel the notion categorically that we're not talking about just primary medical care. We are talking about primary care taking into account both health care as well as the broader socioeconomic determinants of health. That has always been government stance, and that will continue to be government stance. However, the working group on primary care will have to start somewhere first. And that is why we are looking at primary health care as a starting point. And that is what we're going to do first in a phased approach. So to address all those concerns, please rest assured that we are looking at the entire healthcare sector as a whole and not restricting it to doctors. Now, coming back to Dr. Shea's question about what government is going to do and whether we're going to lure our private sector colleagues, no, we don't lure people. We work in partnership with colleagues. And what we will do is to, as the Secretary has outlined in his address this morning, in a three-pronged approach. As for the private sector, because it has done very good work in the last however many decades of taking care of the bulk, really, of ambulatory patients. What we're going to do is to make sure that as we move forward and in consultation with all the stakeholders in all these task forces, that we will be able to increase the quality of care, increase price transparency, and to enhance the patient experience. How specifically we go about it, whether it's through monetary or non-monetary incentives or other ways of doing it, remains to be seen. The government goes into these primary care working groups with an open mind. There is no preset agenda. We truly want to listen to the different stakeholders, and the reason that we all come here today is because we want to listen to you as we put together these packages. So yes, let me confirm that we will be looking at monetary as well as non-monetary incentives. We are going to try to work in partnership with providers, not only doctors but also nurses, as well as other health professionals, and look at how this multidisciplinary team, say in a community health center setting, whether that's its physical co-location or it's a virtual network, can deliver the primary care that Hong Kong people deserve.
Okay, the last question from the general manager.
William Choi, trainee psychiatrist in Castlereagh Hospital. I think I should be the most humble as I'm the most junior doctor. And also I should be proud because I remember I attended tutorial and lecture by Professor Leung in Hong Kong U when I was a medical school, when I'm a medical student. I want to make a comment on how mental health should be expanded or to be integrated more in primary care. There are three main issues I would like to highlight as my experience as a trainee psychiatrist. First, mental illness, for patient mental illness, unlike other illnesses, quite often they refuse treatment because of lack of insight which can be part of the illness or the denial of the illness due to the stigma associated with mental illness. Second, the treatment of mental illness very often involves multidisciplinary support. So in primary care, support of the other disciplines should also be available for mental patients treated in primary care setting. The third issue is the financial one. In Hong Kong, mental illness are not covered in insurance scheme at all. And also, it's quite often for the mental patient to be in a lower social class, which can contribute to the onset of mental illness or as a consequence of the mental illness. So because of these 3 points, I would like to say, I agree that mental care should be expanded in primary care, but in fact, it may not be as easy as it may appear, and it should receive more attention. Thank you.
Thank you. Any response? If no?
No, I think very sound,
Very good points.
good
Very
point.
good points.
Okay, thank you very much for your active participation this morning. Free sitting buffet lunch will be served on the first floor upstairs. Enjoy your lunch and let's meet again at 2:30. Thank you very much.